Dr. KRP, good evening.
Good evening, Dr. Ramesh.
Can we start, Ubal?
We are waiting for Setu Babu, sir. Otherwise, we can start, madam.
Yeah, Ram Subramanian can give his introduction by the time he joins.
Ram, sir, over to you.
Start now.
Dr. GN, you take over. AIG is presenting first. Okay.
For me?
Yes. Yeah. AIG, you can introduce AIG and then I'll start. Okay, please start, Dr. Ram Subramanian. He's our president. Dr. Ram Subramanian is the president of the ISG. So, over to you, doctor.
Good evening, everybody. I welcome you all to this special meeting of Tamil Nadu chapter of ISG. Probably, I think this will be one of the last meetings before we go into the annual meet next time. And we have a lot of interesting topics lined up for today. So we'll start the meeting now. Thank you.
Thank you. Dr. GN?
Good evening, everybody. It's a pleasure to be a part of this meeting. I would say a unique venture, and I hope we have many more of this to come soon. So we start off with the presentations, and I'm joined here by my co-judges, Dr. Naresh Bhatt, Dr. Jayanti, and Dr. Setu Babu. I don't know whether he's joined. Setu Babu, if you've joined, if you could just say hi. Not as yet, but in the interest of time, we will start off. And we have 5 presentations. Each presentation is given 8 minutes and 2 minutes for discussion. I request all the participants to keep a note of the time, keep a tab on the time, and ensure that you finish your presentation within the allotted time. Jayanti, is there a timekeeper? Do we have a timekeeper?
I'll keep the time.
Okay. Thank you. And we will go in the same sequence as has been mentioned here. So the first presentation is from AIG Hyderabad. So may I request the presenter from AIG Hyderabad to please come up and start your presentation. You could introduce yourself and then start off your presentation.
Good evening, sir. Good evening, ma'am. I'm Dr. Shubhankar Godbole from Asian Institute of Gastroenterology, Hyderabad. I'm a third-year resident. Will be starting my case.
Please start.
Yes. So good evening, all. We are presenting a case of a 48-year-old man from Karnataka who presented to us with chief complaints of acute onset abdominal pain 3 months ago, a history of shortness of breath since past 1 month, and fever with chills since past 2 weeks. The patient was apparently well 3 months back when he developed abdominal pain, which was sudden in onset, severe intensity upper abdominal pain, suggestive of pancreatic type. There was no history of alcohol, smoking, prior similar episodes, diarrhea, or steatorrhea. Where the patient did complain of biliary colic since past 2 months. The past history was not significant except for the biliary colics. Personal history and family history were unremarkable, and dietary history revealed adequate nutritional intake prior to the onset of illness. On day 2 and day 5 of the pancreatitis, patient underwent ultrasound abdomen and CT abdomen, which showed cholelithiasis, changes of acute pancreatitis, and an inflammatory mass of around 10 by 10 centimeters displacing the duodenum. There was a hepatomegaly with fatty infiltration of liver. The patient was managed in the nursing home with IV fluids, and the pain subsided, but occasional exacerbations of pain persisted after food intake. About 1 month later, he started noticing upper abdominal lump, which was gradually increasing size, that of wrist. Postprandially, there was slight increase in the size and associated with dull abdominal pain and a weight loss of about 8 to 10 kgs. Endoscopic ultrasound at this point showed a large peripancreatic vault of necrosis in the lesser sac with 30% debris, for which the patient underwent fully covered lumen opposing metal stent placement and wound drainage. Following this, the symptoms gradually improved and the patient gained weight of about 2 to 3 kgs. Around day 45 of the illness, he started developing shortness of breath, which was initially exertional, but later on, even at normal daily activity, an increase in the left lateral position. X-ray chest showed a right-sided pleural effusion, for which therapeutic pleurosynthesis was done. The pleural fluid showed a low protein effusion with elevated amylase levels, and hence a PD leak was suspected, for which the patient underwent ERCP on 27th of October. The cholangiogram showed irregular narrowing at the lower end of CBD. However, there was no stone or sludge on balloon sweep. In the D1, there was a fistulous communication with Vaughan, and hence a double pigtail plastic stent was placed here. LAMS was exchanged with a plastic stent, and the PD cannulation was failed, followed by which the patient developed high-grade fever spikes and shortness of breath, for which he was referred to our institute. Dietary history at this point revealed a significant caloric deficit of 450 calories and 25 grams of proteins. Vitals were stable. The patient showed pallor and edema. Respiratory system showed changes of right pleural effusion. Per abdomen examination was unremarkable, and other systems examination was unremarkable. The provisional diagnosis being considered at this point was moderately severe acute pancreatitis, likely of biliary etiology, onset in mid-September, vault of necrotic collection within the lesser sac, post-drainage status, and a right-sided pleural effusion, which was likely infected, probably from pancreatopleural fistula, malnutrition-related hypoalbuminemia, tubercular, or malignant. Investigations showed a neutrophilic leukocytosis in CBC. RFT were normal. LFT showed mildly elevated alkaline phosphatase and hypoalbuminemia. Endoscopy showed esophageal candidiasis. Cystogastric stent was in place, and there was edema at D1, D2 junction. CECT abdomen was done, which showed a resolving Vaughan with a stent in situ. CBD stent was in situ with left pneumobilia. There was mild ascites and a massive right-sided pleural effusion. Fluorosynthesis showed a normal normal pleural fluid amylase, and ascitic fluid showed a borderline SAG with normal amylase levels. For the pleural effusion, patient underwent a right pleural PCD placement, which drained around 1000 to 1200 ml over the next 10 days without any significant improvement despite of octreotide. Pleural fluid amylase was repeated on a couple of occasions. That was normal. NJ tube was hence placed for nutritional optimization. Evaluation of borderline SAG showed HVPG to be normal. Here we have a patient of acute pancreatitis onset in mid-September. On day 30th, underwent EUS-guided wound drainage, developed right-sided pleural effusion with persistently high output. HVPG was normal and even after nutritional optimization. Hence, we took the patient for MRCP, which showed poor projection of PD in the proximal part. There was a vault of necrotic collection near the head and uncinate process. Distal PD was thin and the proximal PD was not projected. We took the patient for upper GI endoscopy, which showed the previous cystogastric plastic stent almost partially migrated and hence was removed. Two more double pigtail plastic stents were placed in the duodenal cavity, duodenocystic cavity. ERCP showed the pancreatogram showed cutoff at the genu, and hence transpapillary stent was placed inside the cystic cavity. CBD stent was exchanged. In the 15th week, patient developed right upper quadrant abdominal pain, and the imaging was suggestive of acute calculus cholecystitis, for which the patient underwent percutaneous cholecystostomy tube placement. Because of the persistently high output pleural fistula, we took the patient for a sulfur colloid scan, which revealed the presence of tracer in the pleural cavity after 24 hours of injection. Hence, endoscopic ultrasound was done, which showed heterogeneous pancreatic ecotexture. The PD was thin size in the body and genuine body region with mild peripancreatic edema. This is the pre-ERCP. This is the pre-ERCP picture showing a PCC in situ, CBD stent with left pneumobilia, pancreatocystic stent, and three cystoduodenal stents in situ, along with the NJ tube. ERCP showed a cutoff at the genu region. Hence, EUS guided cannulation of EUS guided puncture of PD was done, which revealed a thin pancreatic duct without any significant pancreatic leak. Over the wire, pancreatogastric stent was placed and pancreatic duct drainage was done. CBD showed a lower CBD stricture for which we placed a CBD stent. This is the final picture showing a PCC tube, a CBD stent, transpapillary stent, and a EUS guided pancreatic duct drain. So this is the overall summary of the case. Patient started to have acute pancreatitis in mid-September, underwent EUS guided Vaughan drainage on day 30, developed a right-sided pleural effusion, which was initially having higher amylase levels, which was drained using a percutaneous, drained using a right-sided PCD tube, having high output, persistent pleural fistula. EUS guided pancreatic drainage was done. Post-procedure, the patient's abdominal pain decreased, pleural fluid drain output reduced, and hence the right-sided pleural tube was removed. Also, the PCC output decreased to 50 ml per day, and the patient was discharged after 4 days using with NJ tube and PCC in situ, and currently remains asymptomatic. This is the final diagnosis of the patient: acute pancreatitis, which was moderately severe, likely biliary etiology. Onset on 15th of September with a vault of necrotic collection in the lesser sac, post drainage in late October. Developed acute calculus cholecystitis for which a PCC tube was placed in the late December. The patient was having a right-sided pleural effusion with disconnected pancreatic duct syndrome and a pancreaticopleural fistula, for which he underwent EUS-guided pancreaticogastrostomy.
And take up for discussion. Yeah.
Thank you.
Dr. Naresh, Dr. Sethu Babu.
The first thing is, are we doing it as an examination case, or are we trying to?
No, just in 2 minutes, just whatever is pertinent to the case.
Okay. You think somewhere down the line he needs surgery, or it could have been done early?
Sir, these days, because of presence of EUS-guided pancreatic duct drainage and improved quality of stents, many people don't require surgery. But yes, if the patient had a significant pancreatic duct leak and the pleural fluid would not have been resolved despite of PD stenting, then the patient might have been posted for surgery.
Shubhankar, well presented. My question to you is, why did you select this case and what is the message you are trying to put across?
Sir, this patient had developed a right-sided pleural effusion, which was persistently having a high output. Initially, we suspected it to be because of malnutrition and pancreatic duct leak. However, despite of nutritional improvement, the output remained quite high. The amylase levels were persistently within normal range, and we could not locate the source of leak.
How do you explain that? How do you explain a normal amylase in the pleural cavity?
That was the atypical part, ma'am. Till the end, we were not able to explain the low amylase levels, but resolution of the pleural fluid output after pancreatic duct drainage was probably one factor which led us to believe that it was a pancreatic duct leak.
Dr. Naresh?
I think essentially what Ramesh wanted to ask, I mean, what is the big message here? I mean, you've done a lot of good endoscopic procedures, but what is the message for us?
So right-sided pleural effusions are quite rare to be present with pancreatopleural fistula, and there should be a suspicion of pancreatopleural fistula, especially in the cases of acute pancreatitis or chronic pancreatitis, who develop pleural effusion, which are having high output.
So how did you say malnutrition causes pleural effusion? I'm a little intrigued.
So like hydrothorax.
Because of malnutrition?
How often do you get that malnutrition?
Did this patient have edema, ascites, any other place where, I mean, you're going to link malnutrition with an effusion only through a hypoadenemia, isn't it?
Yes, sir.
So did this patient have any other evidence of hypoadenemia? Did he have edema? Yes,
sir. To begin with, the patient had edema and there was very mild ascites. So that raised us a suspicion whether the patient is having any underlying liver disease or hypovolemia related right-sided pleural effusion. But we still could not demonstrate the leaks. So we had done a sulfur colloid scan in order to see whether there is peritoneal-pleural fistula.
Okay, thank you. Thank you, doctor. Thank you for the presentation.
Thank you very much.
Yeah.
Thank you.
You can answer some of the questions in the chat box, doctor. Okay.
Thank you.
Over to Dr. Naresh to conduct the second case presentation.
The case is from Stanley Hospital. Can you make your presentation? Introduce yourself, please, and make your presentation.
Good evening, professors and honorable dignitaries and colleagues. Myself, Dr. Sriram, from Professor Dr. M.S. Revati Ma'am Unit, Stanley Medical College, Chennai.
You'll have to speak a bit louder.
The slides are not seen as yet.
Sir, myself, Dr. Sriram, from Professor Dr. M.S. Revati Ma'am Unit.
Okay, you please show us the slides, no? Share your slides. Please share your slides. The fourth one, yeah.
Good evening, professors. Today I'm going to present an interesting case capsule, a mysterious neighbor. This case capsule contains two cases.
We are not seeing your slides, Sriram.
Sir, it was coming here, sir.
We're not able to see the slides. No, people who are not presenting, please mute.
No.
Yeah, please start. Please mute.
Thank you. Thank you. Thank you. Mama pasao. Mama pasao. Aao chalo.
Can you please mute, please? Okay, start, doctor.
Good evening, professors. Today I'm going to present an interesting case capsule, a mysterious neighbor. This case capsule consists of two cases.
We can't hear you.
No, he's not talking.
Please move the slide. Yeah, please start. Speak, doctor.
He's having some technical glitches, I think.
Move your slide. Yeah. You can start. Make your presentation.
Coming to case one, ma'am, a 57-year-old male resident from Chennai who is a known chronic alcohol use disorder and smoker, gave me the chief complaints of right upper abdominal pain for 3 months, and this pain is vague, dull aching, continuous, non-radiating pain, and with no relation to food, associated with anorexia and weight loss. However, there are no symptoms, no history of vomiting, postprandial fullness, early satiety, or bowel roving movements, GI bleed in the form of melena or hematemesis, jaundice, or fever. On general examination, it is normal. There is no evidence of pallor, icterus, or no generalized lymphadenopathy. BMI of 19 kg per meter square, and his performance status is 1. On systemic examination, over the right hypochondrium, a mass of about 6 into 7 centimeters is felt, which is hard, nodular, and tender. And the mass, dullness of mass is continuous with the liver dullness. However, there is no bruit or no other masses or free fluid felt. with this above clinical scenario on routine investigations, complete hemogram, RFT, and electrolytes were normal, except for a mild elevation in SGOT, LFT parameters were normal, and viral markers were negative. We proceeded with the triple phase CECT abdomen, which showed a multiple varying size heterogeneously enhancing mass lesion in the both lobes of the liver, largest lesion being 6 into 7 into 8 centimeters in the segment 5 of the liver, underlying liver architecture being normal, portal vein is normal, few subcentimetric porta hepatis and left para-aortic lymph nodes were noted. With this, possibly a multiple liver metastasis was considered. But on tumor markers, serum alpha protein was elevated about 60,800. We proceeded for the looking for primaries. So we did an upper GI endoscopy where a large ulceroproliferative growth in the mid body of the stomach along the lesser curvature is seen, and esophagus and duodenum were normal, and there is no evidence of outlet obstruction. And gastric biopsies were taken from this growth. On histopathology, there you can see the nest of tumor cells were there, but these are not typical of adenocarcinoma. So we have proceeded with the immunohistochemistry, where the HEPAR1 came out to be positive, suggestive of metastatic deposits from HCC. And a final diagnosis of multifocal HCC infiltrating the stomach is considered. And as per Barcelona classification, he belongs to stage C. Medical oncology opinion was obtained. The main part is HCC infiltrating GI tract is very rare, with the incidence of only 0.5 to 2%. And the most common site of invasion being duodenum, followed by stomach and colon. Mode of spread to GI tract is by adhesion of the serosal site of the adjacent organ with the tumor. And treatment of these patients mainly depends upon the stage of HCC, performance status, and GI tract symptoms. Coming to case 2, a 57-year-old male from Chennai who is a known diabetic, chronic alcohol use disorder, and smoker, presented with an epigastric pain for 1 month, associated with awareness of lump in the upper abdomen, anorexia, and weight loss. No history of vomiting, postprandial fullness, early satiety, ball rolling movements, jaundice, fever, or GI bleed. On general examination, except for pallor, there is no icterus, no generalized lymphadenopathy, BMI of 20 kg per meter square, and his performance status is 2. On systemic examination, and a hard mass of 15 into 20 centimeters is felt in the upper abdomen, extending from epigastrium to the right hypochondrium and umbilical region. And the dullness of mass is continuous with the liver, and hepatomegaly is there with a liver span of 20 centimeters. However, there are no bruit or fluid. With the above clinical scenario, we proceeded with the routine investigations, except for mild anemia, other hemogram or renal parameters or LFT were found out to be normal. We proceeded with triple phase CECT abdomen, which showed a well-defined lesion of 18 into 11 into 19 centimeters with a typical arterial phase enhancement and a washout in the portal venous phase, noted in segments 1, 2, 3, and 4 of the liver. Underlying liver architecture being normal, there are no periportal lymph nodes and patent portal vein with minimal ascites. Possibility of primary HCC was considered. So followed with the tumor markers, serum alpha fetoprotein was elevated with 946 milligrams per ml and CE of 17.2. We did an upper GI endoscopy, which showed an ulceroproliferative growth in the antrum. Other esophagus and duodenum being normal without any evidence of outlet obstruction, and biopsies from the growth were taken. On histopathology sites, it is showing a sheets of hyperchromatic pleomorphic cells, which are suggestive of poorly differentiated adenocarcinoma from the stomach. And here the HEPAR1 came out to be negative. So in view of elevated alpha fetoprotein and typical of HCC, we proceeded with the liver biopsy, which showed a distortion of trabecular structures, large and hyperchromatic nuclei and granular cytoplasm seen, suggestive of grade 3 HCC. However, the underlying liver being showing absence of liver fibrosis. So we made a diagnosis of double primary malignancy, both primary HCC and adenocarcinoma of the stomach. Surgical and both medical oncology opinion were obtained. And mainly the double primary malignancy is a synchronous primary gastric cancer with HCC is very rare, and only incidence of about 2 to 10.9%. And there are no guidelines available for managing for these double malignancies. It is treatment is generally individualized. diagnosis of double primary malignancies is by Warren and Gates, where histological confirmation of malignancy is required for both the tumors, and there should be at least 2 centimeters of normal mucosa between the tumors. And if they are in the same location, they should be separated by at least 5 years, and probability of one being metastasizing to the other to be excluded. So these 2 case scenarios shows a mysterious behavior of a liver with the adjacent organ stomach. One thinking in the lines of secondaries to liver, it came out to be a primary HCC infiltrating to stomach. Second came out to be a dual primary malignancy. So we are presenting it.
Thank you, Sriram. What do you think was the reason why the first patient developed an HCC?
Sir, it is a de novo HCC, sir. He is not no viral markers are negative, and he is not an alcoholic is there, but no underlying cirrhosis, sir.
So what then? What do you suspect in that situation?
Any occult?
Can you get HCC without cirrhosis?
If it is an HBV, in hepatitis B infection without having cirrhosis, the patient can have can present with HCC. HBV related.
What was the ultrasound finding in these patients? Why did you go for a CT?
Ma'am, ultrasound, they were, it is inconclusive, ma'am. They told that it is only a mass arising from the liver. So we proceeded with CECT abdomen, ma'am, for both the cases.
I think a good ultrasound should, with a Doppler, could have picked up both the lesions with an alpha fetoprotein of more than 1,000, no?
Yes, ma'am.
Yeah, you already had a clue that it was a tumor.
Yes, ma'am. It was surprise. Actually, we thought it is secondaries. They also reported as secondaries only, ma'am.
But that's okay. Doesn't make a difference in your management, no? That's what I wanted to convey. No?
Yes, ma'am.
Dr. G.
When you presented your first case, you mentioned the liver function test, the SGOT was slightly elevated, the rest was normal. But when I looked at the proteins, there was definitely an age reversal. So that is something that you probably overlooked. Second is, when you're presenting your CT findings, I would be interested in what your radiology thought about the Lirad score, because that is now a standard of reporting as far as CT of the liver is concerned. In neither of those cases that you presented, there was any mention of this Lirad score, because if it's Lirad score, if the radiologist felt that it's Lirad's 5 or 4, I mean, the diagnosis would be that much more certain.
Yes,
and of course, third is you need to answer one question, which I think has come up in the chat box also. The second case, could it be a hepatoid variant of gastric adenocarcinoma with liver mets? Why are you thinking of 2 different malignancies at the same time? I mean, with this diagnosis, you could connect both.
Sir, actually, we asked for medical oncology opinion also, sir. They also are telling it is most likely to be because this liver biopsy also came out to be suggestive of primary HCC. The gastric biopsy suggestive of adenocarcinoma from stomach. Most probably they are telling can be dual malignancy.
You said some IHC marker, no? You said that
yes, sir.
Suggests it was not metastasis. So why don't you defend yourself that way?
Dr. Setu Babu, have any question? Dr. Setu Babu, you're there? Okay, if there are no more questions, we move on to the third presentation from Trivandrum. Can you share your slides, Doctor?
Good evening, judges. Good evening, faculty. I am Dr. Vijay Narayan. I am a senior resident in Department of Gastroenterology, Government Medical College, Trivandrum. Today, I'll be presenting an interesting case which we have titled A Twist of Fate. So, presenting a story of a 58-year-old gentleman, a resident of Trivandrum, who's a rubber tapper by occupation, no comorbidities. He has addictions in the form of smoker of 30 pack years duration, and he does not consume alcohol. He presented with abdominal pain of 1 month duration, loss of weight and appetite of 1 month duration, fever of 3 weeks duration, and yellowish discoloration of eyes and urine of 1 week duration. And his abdominal pain was predominantly in the left upper quadrant, and it was insidious in onset, gradually progressive, a continuous dull aching pain which disturbed sleep. There was no radiation of the pain and not aggravated with food intake or a change of position. It was relieved with analgesics. And he also had an unquantified loss of weight over the past 1 month with a loss of appetite. And he also gave a history of fever, which was predominantly an evening rise of temperature with chills. And there was no history of cough or breathlessness or contact with tuberculosis. And for the past 1 week, he gave history of high-colored urine. And bystanders also noticed yellowish discoloration of eyes for the past 5 days. There was no pruritus or clay-colored stools, no history of intake of CAMs. And in the past history, he gave a history of diarrhea 2 months ago, which was small volume diarrhea, 3 to 4 episodes per day. There were no blood or pus in stools. The history suggests of increased gastrocolic reflex was present. And he took antibiotics from local hospital, and the diarrhea lasted for 10 days and resolved. And following that episode, he had no further bowel complaints, even at the present admission. And he had no comorbidities, no history of any high-risk behavior, no history of COVID-19 infection. And prior to our hospital admission, he had actually consulted a local hospital for his abdominal pain, where he was treated with analgesics and antibiotics. But he had only mild symptomatic relief. So they did an ultrasound of the abdomen from the local hospital, and they found that he had features consistent with situs inversus. His liver was on the left side and spleen on the right, dextrocardia and aorta on the right and IVC on the left. And he also had 2 hypoechoic focal lesions in segment 8 and 7 of the liver, measuring 5 centimeter and 2 centimeter respectively. And so they proceeded with a CECT abdomen from the local hospital itself. It showed features of situs inversus, and as you can see, the liver is on the left side, and there are 2 hypodense lesions in segment 8 and 7. And there is mild peripheral enhancement and perilesional edema. And there are also 2 separate short segment bowel wall thickenings in the distal transverse colon as well as the hepatic flexure. So the radiologist outside gave the possibility of hepatic metastasis with a primary malignancy in the colon. So the patient was counseled regarding the possibility of a disseminated malignancy and that he has an extremely poor prognosis. And he was referred to an Apex Oncology Institute in Trivandrum, which is our regional cancer center Trivandrum. And at RCC, they attempted a colonoscopy, but due to the situs inversus, they had a difficulty in negotiating the colon. And he was referred to our side as a case of probable CA colon with liver metastasis for colonoscopy. So this is when we saw the patient first. On examination, patient was sick looking with an ECOG 3, BMI of 16.9. He had pallor, icterus, plate 2 clubbing, bilateral pitting pedal edema, and he had features of SIRS. And on systemic examination, he had a tender hepatomegaly 3 centimeter under the left costal margin. Spleen was not palpable. TR examination was normal. And on routine investigations, he had a HB of 10.8 with total count of 12,900, 82% polymorphs, ESR of 75, peripheral smear showing neutrophilic leukocytosis, and a microcytic normochromic anemia. Bilirubin of 5.2 with a direct fraction of 2.8, OTPT 164-104, protein 5.4, and albumin of 1.8, and an ALP of 449. He had a CRP of 45. And viral markers and COVID were negative. Tumor markers were all negative. And stool routine did not show ova, cyst, or parasites, and smear did not show strongyloids. Chest X-ray and ECG was a history of dextrocardia. And we did a colonoscopy. Scope was passed up to cecum. And as you can see, the IC valve here is seen on the right side. And there are multiple discrete punched out ulcerations in the cecum, ascending colon, hepatic flexure, and transverse colon. Rest of the colon was normal, and he had small hemorrhoids. So we took biopsies from the ulcer as well as segmental biopsies and sampled. So we suspected one DD was tuberculosis. So we sent samples for tissue CBNAT to rule out idiopathic TB as well. And we did also an ultrasound abdomen from our side in the same setting. It showed 2 large, well-defined hypodense lesions in segment 7 and 8. Largest was 10 centimeter in segment 8. And the lesion was subcapsular, and there was a risk of impending rupture. So we consulted our intervention radiologist, and he did a pigtail drainage into the large lesion in segment 8, and it drained dirty brown colored pus. And so we did an amoebic serology, which was strongly positive. So you can see, and the tissue CBNAT for tuberculosis came as negative. Upper GI endoscopy was negative for H. pylori or dysplasia. And blood culture and sensitivity grew Acinetobacter sensitive to PIP-TAS. And pus culture and sensitivity, there was no growth. And the histopathology from the colonoscopic biopsy specimen showed multiple, as you can see, there are multiple trophozoites of Entamoeba histolytica with vacuolated cytoplasm, ingested RBCs, and small nuclei. So we treated the patient with PIP-TAS for Acinetobacter and metronidazole for the amoeba, and pictorial drainage was continued. The patient's general condition and appetite improved dramatically within 4 to 5 days. And the initial 5 days, the pictorial catheter drained brown colored pus, and the repeat USG showed that the abscess cavity was shrinking. However, after 1 week, bilious fluid started to drain from the catheter, and fluid analysis was also suggestive of bile, corresponding to a bile leak. And the USG showed that the IHBRD was persisting. So we proceeded with an MRI MRCP, which showed peripherally enhancing fluid collections in segment 7 and 8. And the segment 8 lesion was 4 centimeter in size, hypointensity in T1, hyperintensity in T2, and no diffusion restriction. And the collection also showed a biliary communication with the adjacent biliary radicals. It was suggestive of a predominantly bile collection. So we did our interventional radiologist told that we needed to do it was better to do an ERCP to decompress the biliary system prior to pigtail removal. So we attempted a side viewing endoscopy, but the ambula was on the opposite side. So in view of situs inversus and anatomical variations, we had difficulty in calculating the CBD. So we decided to continue antibiotics, and after discussing with the interventional radiologist, the pigtail catheter was later removed and the patient was kept under close follow-up. And after 6 weeks, the patient had dramatic clinical improvement from ECOG 3 to 1. His appetite improved. He gained weight from 50 to 56 kilogram. Follow-up USG showed that the lesions had significantly reduced in size. There was no ISPRD. Repeat colonoscopy showed healing of the ulcers, and biopsy showed no evidence of amoebic colitis. So the final diagnosis is amoebic colitis, amoebic liver abscess, Acinetobacter bacteremia, transient biliary leak post-pigtail drainage, and situs inversus totalis. So conclusion, chronic amoebiasis accompanied by an amoebic liver abscess may be misdiagnosed as metastatic colon cancer. A high index of suspicion is essential for the diagnosis, especially when dealing with colonic masses and liver lesions, especially in the tropics. Thank you.
Thank you, Vijay. Now that we know what the diagnosis is, I mean, maybe for old timers, it would seem pretty straightforward, but where do you think the mistakes were made on a retrospective thing? Can you point out at least 3 or 4 areas where we could have avoided making a mistake of calling it a cancer?
So one thing was that the patient had a predominant complaint was fever. So infectious etiology should have been thought out at that point itself. But when from the local hospital, but they were treating him for his abdominal pain, and they got misled by the ultrasound and the CT of the focal lesions. Probably.
Be brief. One was fever. What else?
One was fever, sir. Then he had a features of SIRS, neutrophilic leukocytosis in the blood routine, and then features of SIRS were there. Neutrophilic leukocytosis was there, and he had jaundice also, and fever with jaundice and liver lesions. So, and he had tenderness in the left hypochondrium, but he has situs inversus. So his liver was on the left, and he had tenderness there. So with fever and tenderness over the liver, we should have suspected a liver abscess.
Exactly. Yeah.
Vijay, good presentation. What does literature have to say about the spontaneous communication between the abscess cavity and the biliary system? Do they subside by themselves? What proportion of patients would require a biliary intervention?
So in the literature, when we there are a few cases reported, but when we searched most cases, it required intervention. We were also planning an intervention actually, but we also tried for an ERCP, but we had difficulty. So we just decided to follow up the patient. But thankfully, this patient improved without an intervention. When we searched the literature actually regarding ERCP in situs inversus, well, there were very few case reports. Between 1985 and 2015, there were only 8 case reports in literature of successful ERCP in situs inversus. So we had difficulty. That is why we followed up the patients.
Any other clinical condition that could have given rise to this combination of symptoms? You had a patient presenting with liver SOLs, which initially also looked very much like an abscess, and a sigmoid colon thickening, which led you to think of a malignancy in the colon. But anything else that could have also caused this sort of a problem?
2 other differences we considered. One was tuberculosis, sir, and other was lymphoma, because he had a evening resting temperature and fever, and liver lesions as well as thickening. Then
but I think the changes, the rim-like sign in the CT was quite suggestive of more of an inflammatory rather than a malignant pathology. Thank you, doctor. Thank you very much for your presentation.
Thank you.
We now move on to the next presentation from Jitmer. Kindly share your slides. Dr. Sethu Babu, I request you to have your inputs. Please put on the slideshow. Yeah. Yeah, please start. Introduce yourself and start. I can't hear you. Doctor, we can't hear you. Are you muted?
Good evening, everyone.
Yeah.
Myself, Dr. Shivakrishna, Senior Resident from Medical Gastroenterology, JIPMER. I thank ISG TNC, the respected teachers who joined the session, and my teachers, Valneval Mohan sir and Senthimil Selvan sir, for giving me this opportunity to present a case. Recurrent abdominal pain in a young woman to handle the cause. A 21-year-old woman presented with epigastric pain for 1 week, which is deep boring, moderate to severe, continuous, radiating to back, aggravated on lying down and decreased on sitting and leaning forward position. There is no vomiting, fever or jaundice. There is no abdominal distension or abdominal lump. There is no edema, breathlessness or oliguria, no GI bleed, no steatorrhea, no polyuria, polydipsia, and there is no history of trauma or drug intake. She had similar discrete episodes of pain in the past, 1 to 2 per year for the initial 4 years and 1 to 2 per month for the last 3 months. And she noted weight loss of 5 kgs in the last 3 months. She is not a diabetic or hypertensive. She doesn't smoke or take alcohol. There is no family history of pancreatitis. She is unmarried with normal menstrual cycle. She takes non-vegetarian and she has decreased appetite and altered sleep pattern. 1 month back, CT abdomen was done and she was treated with IV fluids and analgesic. To summarize, a young woman with 4-year history of recurrent pancreatic type pain has increase in pain frequency requiring frequent hospitalization and daily analgesic the last 3 months with no obvious exocrine or endocrine insufficiency. So the possibilities of recurrent acute pancreatitis and early chronic pancreatitis were made. On examination, there is a tachycardia, BMI of 16 and pallor is present and mild epigastric tenderness noted. Her hemoglobin was 10.4 and lipase is elevated 5 times above the upper limit of normal and rest of the lab parameters were within normal limit. So recently done contrast CT images were reviewed which shows prominent main pancreatic duct in the body and tail of the pancreas and there is no obvious parenchymal atrophy or calcifications noted and there is hypodense foci within the dilated main pancreatic duct in the head and which radiologists reported to consider a cystic neoplasm. And coronal section, CECT, shows prominent CBD. And this is the ventral pancreatic duct, which when traced makes a loop, initially descends down and then ascends and drains in the region of the minor papilla into the duodenum. So diagnosis of dilated pancreatic duct, dilated side branch duct or a dilated accessory duct was made. In order to further characterize this lesion, we have done an MRCP with MRI abdomen which showed a dilated main pancreatic duct with filling defects with the hypointense foci which was suggestive of calculi. But the ductal anomalies couldn't be ascertained. So linear echoendoscopic ultrasound showed this anechoic structure is the pancreatic duct which appears dilated. And we can see the pancreatic concretions noted on the endoscopic image at the ampulla. And this is the dilated main pancreatic duct, which is studded with multiple calculi. And one of the hyperechoic foci is seen descending inferiorly, and it is continuous with a duct. Curved duct, which is ascending above and crossing the main pancreatic duct and joining in the region of minor papilla in the proximal region. So diagnosis of chronic calcific pancreatitis with a ductal anomaly in the form of ansa pancreatica was made. So we have taken the patient for ERCP. Main pancreatic duct was cannulated. Pancreatogram showed dilated pancreatic duct with a filling defect and an accessory duct arising from it. So sphincterotomy was done and clearance of the main pancreatic duct was achieved. So patient came back after 1 week with recurrence of pain. So this time we tried to cannulate through the minor papilla. After multiple attempts, we were able to negotiate the guide wire through the limb of ansa pancreatica. and the guide wire exited through the major papilla. Fluoroscopic image showed the sigmoid loop and sphincterotomy was done, and we were not able to remove the concretions from the ANSA limb. So we placed a plastic stent in order to facilitate the drainage. We completed the procedure by placing a plastic stent into the main pancreatic duct. This is a fluoroscopic image. The end of the procedure, 2 stents were noted, one in the main pancreatic duct and the other in the ANSA limb. So follow at 8 weeks. Patient is pain-free and she doesn't require any analgesics, and she's tolerating solids with a weight gain of 2 kg noted. So our plan is to repeat ERCP and remove the concretions in the ANSA pancreatic duct. So ANSA pancreatica is a congenital ductal anomaly, which is rare, and its prevalence is 1.1%. ANSA in Latin means hand-in. So during embryonic development of pancreas, the duct of Santorni gets obliterated and is replaced by an inferior duct arising from the inferior part of the main pancreatic duct, which descends initially, takes a loop, and then ascends and drains into the minor papilla. What is its clinical significance? It is a predisposing factor in idiopathic recurrent acute pancreatitis. And there is inefficient drainage from the head of the pancreas due to relative obstruction and impervious minor papilla, which is seen in 79% of patients with ANSA pancreatic. It increases the technical difficulty and the probability of failure of endoscopic access to minor papilla. So to conclude, it is a less known and underdiagnosed ductal anomaly, and the sigmoid loop resembles a cystic lesion on imaging. So there should be a high index of suspicion and awareness for both radiologists and gastroenterologists. And the association with recurrent pancreatitis, is it a cofactor or a causal relationship, is debatable. And the evidence for the role of therapeutic intervention is limited. Thank you.
Nice case. Dr. Naresh?
Shiva, what was the logic in putting that stent from the minor papilla coming into the major papilla? What is the logic for that?
Yes, sir. Actually, we tried to negotiate that wire into the main pancreatic duct, into the body and tail beyond the origin of ANSA pancreaticus. But after we tried many times and we are not able to place. So to facilitate drainage, we have kept a stent across the ANSA loop from via minor papilla, and it came out through the major papilla.
But what is the logic? You couldn't get in that side. So, but why put a stent? Could you have just
it is fully studded with concretions. So in order to facilitate drainage, and we don't know the cause for the pain, whether the concretions were the cause for pain due to the inadequate drainage from the region of the head. Because the prior ERCP, we were able to retrieve the calculi in the main pancreatic duct, and patients still came back after 1 week with pain abdomen. So we thought the concretions were responsible in the ANSA limb. The concretions in the ANSA limb were responsible for the pain. So we are not able to retrieve the calculi. So at least we kept a stent so that patient will be devoid of pain for till she comes for the next follow-up.
There's a role for surgery in this patient? Any role for surgery because there are so many stones all around?
Yes, ma'am. But I think we wanted to try one more attempt in her.
Most of the stones are in the head region or in the main duct? Or
yes, ma'am. It's in the head region.
Head region. So do you think there's a role for surgery, ideally?
Actually,
what's your thought process on that?
We wanted to attempt one more time, and we wanted to try retrieve the calculi from the.
The stones are quite large, no? Unless you have ESWL.
Yes, ma'am. There are 8 millimeter around.
Because it's a head region, so bigger surgery or one of those surgeries where you do head coring and just do a ductal jejunostomy that sorts out all the problems. Dr.
I would like to ask you a question based on your presentation. What is the link which connects ANSA pancreatica with idiopathic recurrent pancreatitis? I would think that ANSA pancreatica is probably an incidental finding. The link connecting these two are very weak. I don't think we are in a position to say that ANSA pancreatica would be one of the causes of idiopathic acute pancreatitis. What would be a response to that? The second is a head predominant disease with a dilated pancreatic duct all along the body and the tail. I think we should be looking at a surgical option because, frankly speaking, I don't think I would be very confident of having excluded a cystic neoplasm even now. And the EUS images that you showed, they're all intraductal filling defects, but there are no features classical of stones that were shown on the EUS images that you displayed. So I would still think that we have not been able to rule out cystic neoplasm, and surgery should be option number one.
Thank you. Thank you, doctor. You have any comments to make? Your last comments, Dr. Shiva?
Yes, ma'am. Actually, a question Sir asked, we were also thinking that the ANSA pancreatic is a cofactor rather than the cause for this pancreatitis. And like as Sir said, initially on the CT, the pancreatic duct is just prominent. But the next follow-up she came when we did MRCP and MRI, the pancreatic duct in the body and tail is also dilated. So what we are thinking were that calcifications which are present in the ANSA limb were sagging down and coming and filling into the main pancreatic duct, causing this obstruction. So as I said, like even surgery can be a good option for her. Yes,
it is the best option. I would consider that as the best ideal option. Thank you, doctor, for the nice presentation. We go on to the last presentation from Ramaya Hospital, Bangalore.
Good evening, respected teachers. I am Dr. B. Shruti Sagar from Ramaya Hospitals, Bangalore, and I'll be presenting an interesting case scenario today. So this patient was a 29-year-old lady, a primigravida with 23 weeks of gestation. She presented with pain abdomen predominantly in the right upper quadrant, which was dull aching, continuous type, which was radiating to the back, exacerbated with meal and partially relieved on leaning forwards. And this was since the last 2 days. She also gives a history of non-projectile, non-bilious vomiting, 2 to 3 episodes per day since the last 2 days. However, there is no history of any fever or jaundice, breathlessness, or any altered sensorium. She did not give any history of trauma or drug intake, and she was never admitted to the hospital in the past for similar or any other illnesses. On examination, she was found to have tachycardia and tachypnea. Her sensorium was well maintained. Examination of the parabdomen showed a diffuse tenderness with guarding. Murphy's sign was negative. There was no organomegaly. The uterine height corresponded to 23 weeks of gestation, and the bowel sounds were sluggish. Examination of other systems was normal, and the fetal heart rate was 140 beats per minute. So at this stage, we were thinking about an acute abdomen that could be pregnancy related or non-pregnancy related. We had taken an OBG consult and they thought of abruption of the placenta, polyhydramnios. They were also thinking of a ruptured uterus or an abdominal pregnancy, but because the uterine height corresponded to the 23 weeks of gestation, this was less likely. And so we looked at the abdominal causes and we thought of pancreatitis, cholecystitis, a probable choledocholithiasis, or a mesenteric vein thrombosis, or a Budd-Chiari because of the hypercoagulable state associated with pregnancy. So coming to the lab parameters, she was found to have an elevated leukocyte count with total leukocyte count being 25,800 cells per cubic millimeter. She was found to have a pre-renal AKI with an elevated blood urea nitrogen and elevated creatinine. Serum amylase and lipase was significantly elevated, and the liver function test showed a hypoproteinemia and hypoalbuminemia. ABG was showing severe metabolic acidosis, and the ultrasound abdomen showed the liver with a normal echotexture, normal gallbladder, and normal common bile duct with no intrahepatic biliary radical dilatation. Pancreas was obscured by bowel gas. Both the kidneys was normal in size and echotexture. Uterus was showing a single live fetus corresponding to 23 weeks of gestation. There was mild ascites and bilateral minimal pleural effusion. At this stage, the preliminary diagnosis was a gravida 1 para 1 23 weeks gestation with acute severe pancreatitis, index episode, day 3 with a BISAP score of 3, with an organ failure with AKI and metabolic acidosis. So it sent an etiological workup for pancreatitis, and the serum triglycerides turned out to be normal. However, the serum calcium levels were found to be elevated. With the albumin being low, the corrected calcium was even higher. So We looked at causes of hypercalcemia in pregnancy. When the serum calcium levels are more than 14 milligrams per deciliter, like in this case, it could lead to hypercalcemic crisis and could be associated with somnolence, coma, obtundation, and renal failure. The most common causes in literature for this are primary hyperparathyroidism, granulomatous disorders, drug-induced, that is vitamin D toxicity. The rarer causes being milk alkali syndrome, familial hypercalcemic hypocalciuria, or a humoral hypercalcemia of pregnancy. So we are facing with two issues here: managing the mother for pancreatitis with fluid and pain management, how to manage the hypercalcemia, and how to manage the organ failure, that is AKI, and how to prevent fetal distress while controlling the maternal morbidity. So we look at how managing the pancreatitis with hypercalcemia in pregnancy differs from a non-pregnant patient. So normally we would look at fluid resuscitation with a 15 to 20 ml per kg bolus, followed by maintenance of 5 to 10 ml per kg. We know that Ringer's lactate is the fluid of choice. For pain management, we use the WHO step ladder and ascend based on the requirement. For hypercalcemia, we can use volume expansion with the 4 to 6 liters of IV fluids over the first 24 hours. Other options would be bisphosphonate, cinacalcet, and calcitonin for crisis. And AKI, if not responding to fluid resuscitation based on other indications, we do a hemodialysis. But in the pregnant patient, all the options are not on the table. So fluid resuscitation would be same as a non-pregnant patient, but in the WHO pain ladder management, paracetamol is the safest, being the category A drug, but opioids could lead to severe fetal impairment with congenital heart defects, gastroschisis, seizures, and respiratory depression, along with IUGR. So opioids need to be avoided. Along with that, hypercalcemia management, diuretics are best avoided. Volume expansion is done. Bisphosphonates and cinacalcet are category C drugs for pregnancy, so those are off the table. And calcitonin can be used for crisis. AKI with fluid resuscitation and hemodialysis can be managed. So in this case, we had done a fluid resuscitation with 2.5 liters given on the first day. Pain was fortunately managed only with paracetamol, and calcitonin 200 international units subcutaneously twice daily was given, and 3 cycles of heparin-free hemodialysis was done on 3 consecutive days. Following which the serum calcium levels reduced from 14.8 to 11. The AKI had resolved with creatinine coming back to 0.8. The investigation we had sent on day 1 for radiological workup for hypercalcemia came back on day 3, that is for a serum parathyroid level, and it was parathyroid hormone level, and it was found to be significantly elevated with the more than 2,500 picogram per milliliter, and vitamin D was low. For this stage, we were looking at acute severe pancreatitis with a bisapia, organ failure with AKI and metabolic acidosis, etiology being hypercalcemia secondary to primary hyperparathyroidism in a pregnant lady. So primary hyperparathyroidism in pregnancy, as I've mentioned, could lead to hypercalcemic crisis, pancreatitis, renal failure and nephrolithiasis, neuropsychiatric symptoms, and muscle weakness. Neonatal complications could be in the form of intrauterine growth retardation, low birth weight baby, preterm delivery, or intrauterine death at the extreme. 7% of patients with primary hyperparathyroidism can go to hypercalcemic crisis. Now to look at the cause for primary hyperparathyroidism, what are the imaging options that we have in pregnancy? So USG neck is safest and cheapest first diagnostic test that can be done to look at an enlarged parathyroid gland. The next best option would be an MRI neck to assess the parathyroid anatomy prior to surgery if we are planning a surgery. Ideally, we would like to do a SESTA-BB scan to look for to plan the surgery prior. If you want to do it in a pregnancy, the dose of radiation must be reduced to 50% from the standard 20 millicurie, which reduces the fetal exposure as well. CECT, of course, we would not want to do in a pregnant patient. So initially, we had done a USG neck, which showed a heteroechoic lesion, which was 2 by 2 centimeters posterior to the right thyroid gland, possibly a parathyroid adenoma. We had went ahead and done a MRI neck and thorax as we were contemplating surgery to plan the know the anatomy. There was a lesion in the neck base on the right side, posterior inferior to the right lobe of thyroid. It was hypointense on T1, and T2 showed a mixed intensity lesion, and it was extending into the superior mediastinum. And the same setting, an MRI abdomen was done to confirm the severity. It showed an acute pancreatitis with a small retroperitoneal collection and no complications. So we went ahead and did a surgery. It was an elective parathyroid adenoma resection. There was a 4 by 3 centimeter adenoma on the right side, which was very close to the carotid and the internal jugular vein. Intra-op, the PTH levels was measured 5 minutes after resection, and there was a significant parathyroid hormone level drop from 74 picograms to 248. So there was more than 50% decrease, which suggests adequacy of resection. On histology, we were expecting a parathyroid adenoma, but there was nuclear atypia, and there were increased trabeculae, and there was a glandular acinar pattern, which concluded as an atypical parathyroid adenoma, which differs from a typical parathyroid adenoma with having the following features like incomplete invasion of the capsule, fibrous bands or increased trabecular growth, and increased mitotic activity, and a tumor necrosis. Atypical parathyroid adenomas account for less than 1% of all parathyroid tumors and have a more malignant potential than a typical parathyroid adenoma, and they're not associated with the MEN syndromes like the typical parathyroid adenoma.
How was the patient? You can just conclude, doctor. Just you can just summarize.
Yes, sir. So there was another problem post-op, madam. There was a precipitous calcium drop, and she had a hypocalcemia with the Chostek's and Trosses being positive. So at this stage, she developed a hungry bone syndrome with hypocalcemia, hypophosphatemia, and hypomagnesemia. So we had managed with the calcium and vitamin D supplementation, and she had, finally the calcium levels and vitamin D levels came back to normal, and she was discharged. She had a successful delivery at 9 weeks. The indication through LSCS, she had a severe IUGR. That was the indication. A baby of 1.92 kgs was born, and on further follow-up at 7 and 12 months, the calcium and PTH levels were actually high normal, but the calcium levels came back to normal. This was a summary of the progress that this patient had.
We got the message. Thank you.
So the take-home
message. Thank you. Yeah, we got the message. We can just take up 1 or 2 questions.
Yes, thank
you. Dr. G and Dr. Naresh, Dr. Sethubabu.
Why did you take this patient up for a presentation in a GI forum?
Sir? Just like management of pancreatitis in pregnancy, the differences from a normal patient to highlight those, and how would the challenges to we're facing for imaging, for instance, to diagnose a parathyroid adenoma, and to highlight these issues we wanted to present.
Okay.
If she had come with the 30th week or 32nd week of pregnancy with a pancreatitis and PTH elevate with a parathyroid adenoma,
yes, sir.
What would have been your approach? We had a similar case at 32 weeks of pregnancy, pancreatitis due to parathyroid adenoma.
32 weeks, we'd probably contemplate inducing labor along with the management after she stabilizes.
And basically manage her with the IV fluids keeper and probably take her till about 37 weeks and then deliver.
Yes.
We don't really do. You are lucky enough to do, she came during 23 weeks of pregnancy.
Yes, sir.
Sometimes they do come very late and then she needs to be hospitalized and then take it through because of her worsening pancreatitis and hypercalcemia.
Yes, sir.
And what
no, nothing much. A challenge, which is a challenging situation, I think, which was well handled. I think you're lucky that she could deliver a baby at of 1.92 kilos, but I thought the management was quite okay. Only thing is, there's a question on the need to maintain with vitamin D. What is your comment on this?
Yes,
these patients would have to be maintained on vitamin D.
So because of the sudden withdrawal of the parathyroid hormones, there tends to be the hypocalcemia and hypomagnesemia and hypophosphatemia. So vitamin D supplementation is required for some time to maintain the serum calcium and phosphate levels.
The other thing is in acute pancreatitis, normally you have a fall in calcium, no? So normally they say when the pancreatitis subsides, then you start evaluating the calcium once again.
Yes.
It is surprising that this patient with acute pancreatitis in fact had a hypercalcemia. Can you comment on that?
So normally, because of the calcium forming complexes with the free fatty acid and albumin and soap formation, we tend to have a hypocalcemia. But here the calcium was actually very significantly high with the parathyroid hormone driving the bone resorption. So probably that.
Thank you, doctor. Thank you.
Thank you.
Dr. GN, you can conclude the session and we can send off the marks to Dr. Ubal.
I think I would like to congratulate all the 5 centers and the presenters all of you stuck to time except for the last presenter who exceeded time, because time is always a very, very important factor in these presentations. The quality of cases are also good. As a message to all of you, I think you should, some of you did it, but then there should be 1 or 2 slides on why you are presenting and what is the take-home message. So your presentation should end with these 2 slides. Only then your presentation is complete. But otherwise, I think it was of quite a good standards. Thank you very much.
On behalf of the Tamil Nadu chapter of the ISG, I wish to thank all the presenters. It was a wonderful presentation. And our judges, Dr. Sethu Babu, Dr. Naresh, and Dr. GN to coordinate with me. So we conclude the session. We'll send off the marks to Dr. Ubal, and he will mention the results somewhere down the line. Over to you, Dr. Ubal. Thank you.
Thank you, madam. And I'll announce the results at the end of the meeting. Thank you. We move on to the secretary report before the CME. Good evening, everyone. And next slide. So we are into the 5th month of TNIG CRC study. I welcome other topics because March we are having our annual meeting. I request people to send any multi-center studies for this year. Next slide. So our TNIG guidelines for rodenticide poisoning was published through our GF issue. We hopefully promote these guidelines across Tamil Nadu as well as through the...
Ubal, no slide, no slide.
One minute, sir.
Got it, Ubal.
So we should promote these guidelines across the medical society as well as the pediatric society. We are also formatting through the government side also. Next slide. So our national meeting is going to be a virtual meeting. It will be February 12 and 13. So we don't have any monthly meeting next month. TNIGCon 2022 annual meeting is planned at Chennai. Hopefully we'll have a physical meeting. Next slide. The GF, the second year, the volume 2 issue 1 was available now, both print and online. The print issue will be distributing the coming weeks. Next slide. We have a few number of new members. There are 2 PGs. Next will be, all others will be consultants. Next slide. So this coming to the CME, I think this is suggested by Professor Jayanti, whether we call upon all the southern chapters to have a meeting. Initially, we thought of physical meeting, but prevailing the situation, I think we opted for this virtual meeting. I thank the course directors, Dr. B.S. Ramakrishna and Professor Jayanti, to coordinate the session further on. Over to Dr. Jayanti and Ramakrishna. I request the chairpersons for the first session, Dr. Ravi and Paramanayam, to take over the session.
Over to the chairpersons.
Good evening. Can you hear me?
Yeah, we can hear you, Ravi.
Yeah, the cystic neoplasm is a common disorder nowadays because of wide prevalence, use of cross-sectional imaging, and also because of the quality of the imaging. The time allotted is very short. It's only 20 minutes. I think without taking much time, I will request Dr. Matthew Philip to go to the topic straight away.
Am I audible?
Yes, sir.
My slides are seen there?
Yeah. Yes, doctor.
Very good evening. First of all, I congratulate Tamil Nadu ISG for creating such an event of collaborating all the southern states and having some scientific discussion during this difficult or challenging times of COVID. Pancreatic cystic neoplasm, that is the topic which is being discussed. And you know that, as Ravi told, is a very vast topic, and discussion in 20 minutes is not probably right, but I will just brush through that. We know that it's a relatively common disease, especially after the abdominal imaging modalities have improved the quality of it, and the number of cases of imaging also has increased. So the pickup rate is also increased. And also notice that it increases as age advances. It may go up to 37% by the age of 18 or 80 years old. And why it is important is, now this cystic neoplasm have a malignant potential. So you need to have a very accurate diagnosis, and you also find out the risk strategies so that the treatment can be made well. So in my talk on this approach, I will be just touching upon the introduction, classification, clinical features, how to diagnose this, and what are the treatment options available, and the surveillance of this. We look at the classification of cystic lesions of pancreas. You have got epithelial neoplastic and epithelial non-neoplastic lesions, which I'm not going into details. There are different types of it, but I think what we are discussing more of is the epithelial neoplastic lesions. When you look at the non-epithelial non-neoplastic lesions, we are very commonly coming across the pancreatic inflammatory cyst, and sometimes this becomes a difficulty in differentiating between these two. When you look at the WHO classification of cystic neoplasm of pancreas, and we have 4 different types, as we know that there are different subtypes also on this, which I'm not going into detail. So basically, we have serous cystadenoma, mucinous cystic neoplasm, and intradactyl papillary neoplasm, and solid pseudo papillary neoplasm, otherwise known as SPED. And coming to serous cystadenoma, it is very commonly seen, and the appearance on imaging is very classical, and the diagnostic accuracy of imaging is almost more than 50%. And in pathology, you get something like that, a cuboidal epithelial cells stored with the glycogen. And natural history is a slow growing growth. And sometimes the cyst is of bigger size, more than 4 centimeters, to grow faster. And the classical feature is actually a central scar, and sometimes it may be even calcified, but it is only seen in 15-20% of people. Coming to the mucinous cystic neoplasm, it almost occurs exclusively in women, and it is because there is a presence of ovarian-like stroma, and that's why it's more common in females. On imaging, we have uniocular cyst, and mostly in the body or tail, and occasionally it has got peripheral calcification in a quarter of patients. It has a high malignant potential, and resected tumors, nearly 15% has got tumor in that. But if the size of the tumor is less than 3 centimeters, the chances of tumor is less. And the malignant transformation is suspected when there is cyst is larger size, more than 5 centimeters, or a thickened or irregular cyst wall, or there is an internal solid component or mass is seen, or a calcification of cyst wall is seen. Coming to intradactyl papillary mucinous neoplasm, which is much more common, and we have radiological as well as histological subtypes, and it is quite relevant because of the risk of malignancy is quite high. We have 3 main morphological types, that is the main duct IPM, branch duct IPM, and a mixed one. Main duct has got the highest malignant potential, almost 60 to 80%. And you can have a diffuse dilatation of duct or a segmental dilatation, and ductal dilatation more than 5 millimeters is considered to be significant. Coming to branch duct, it arises from the branches of a non-dilated main pancreatic duct, and it has got a malignant risk of almost 3 to 20%. You also have mixed type IPM, which almost behaves just like comparable to that of main duct IPM, and here actually you have both branch duct as well as main duct dilatation seen. What are the high-risk features of malignant IPM? When you see an IPM, if there is a solid component like a neural nodule or an enhancing nodule, and if the main pancreatic duct is dilated more than 1 centimeter, presence of jaundice, and if you get a cytology of high-grade dysplasia or cancer, then it is evident that it is a malignant neoplasm. So what will be the risk factors for malignancy, either on follow-up or on surveillance? If there is a rapid growth of the tumor, of the cyst. If the patient is obese, if there is smoking, if there is a history of extrapancreatic malignancy, all these favors that these people put as a considered as a risk factor for growth. So if you look at the histological types, you go to gastric, intestinal, pancreatic, oncocytic, and all has got a high incidence of malignancy. And the common one is intestinal or the gastric variety. Coming to the less common one, that's a solid pseudopapillary neoplasm. The lesions appear solid or cystic, typically occur in young women. And it also has malignant potential, and it has got cystic spaces, which has hemorrhage as well as cholesterol clumps. And it alternates with solid tissue. That is why it's called a SPN. So coming to the clinical features and diagnosis, I think the most important challenge sometimes comes is the differentiating between a pseudocyst or inflammatory cyst of the pancreas from that of a cystic neoplasm. I think the most important there is the history. If there is a history of moderate to severe pancreatitis and the patient present with a cyst, I think we have to give a more likely possibility that is a pancreatic pseudocyst. And also on morphology, on imaging, if you got anechoic, thick walled, and no septations commonly, all these favors probably this is actually a pancreatic pseudocyst. But I am coming to the cystic neoplasm later.
Blanket is already there.
When you look at the demographic and clinical features of pancreatic cystic neoplasm, we know that its age of presentation can be variable, and SPN is like the one occurs at the lowest or youngest age group, and it is also common in females, and most of these tumors are more common in females. And but IPMN is almost equal in gender distribution. Clinical presentation, most of the time it is incidental, except when it becomes symptomatic because of pressure symptoms or infiltrating into the bile duct, etc. And imaging features are quite characteristic, which I'll come to later. And all has got malignant potential, except that of serous cyst adenoma. It is actually negligible, or we can say practically nil. Coming to diagnosis, the most important is a cross-sectional imaging. And before you do a cross-sectional imaging, well, you have to ask certain questions. Is the cyst malignant? Is it a mucinous cyst? And if it is mucinous, what is the malignant potential? And out of the cross-sectional, the most important cross-sectional imaging is MRA with an MRCP. Why it is MRA is superior is because it is found that this actually any fluid containing tumors are better diagnosed with the MRA. And is also try to find out the type of the cyst and also help us to find out where there is a communication between the main pancreatic and the cyst. And this is greatly of advantage for branch-necked IPMN. If MRA is not possible, then you have to do a CT scan. Otherwise, MRA is always preferred. This is just a serous cyst adenoma of an MRA, which actually shows the microcystic lesions, and this is a honeycombing appearance on what you see in endoscopic ultrasound. A mucinous cyst adenoma, where it's actually a single cyst, but the wall is thickened and favoring for more favor of a mucinous cyst adenoma. And this is a main duct IPMN. This is a branch duct IPMN. This is a solid pseudopapillary neoplasm, and we can see the mass there and with the cystic spaces. So what is the basic difference between mucinous and serous histology is actually in cystic spaces in a mucinous tumor is actually covered by high glandular epithelium containing mucus. But in serous histology, it is actually covered by a low glandular epithelium. That is why you get a difference on that, and the malignant potential is high also on that. What all endoscopy, or when you do endoscopy patients with the endoscopy, pancreatic cyst neoplasm, and mostly it is diagnostic use now. It will tell you the morphology of the cyst. You can also do a fluid analysis. You can do an FNA from the solid areas. You can do advanced procedures like through the needle biopsy. You can also do, if facilities are available, you can do laser endomicroscopy and contrast enhanced studies. They're all not well established. And sometimes, when in doubt, we are seeing a dilated main pancreatic, you can do side viewing endoscopy and look at the ambulatory orifice and find out there is a fish mouth appearance or mucin coming out of that. And in rare situations, you can even do a pancreatoscopy. So coming to the role of EUS, almost all the guidelines recommend that EUS comes in the algorithm of management. And I'm not going to details of it. The one advantage is that when you see a solid area, especially a mural nodule, we can do a Doppler study and find out that there is a vascularity available, that because this can be compared with that. Sometimes you get confused with the debris material. You can even change the position, or you can put a contrast, Doppler and find out. And this is a case of IPMN. You can see the ambulatory orifice with a lot of mucin there. And you are showing a mass there, and you can do an FNA from that. So a side meanscopy and followed by a mass, you get a diagnosis of that. And also you can do a cyst aspiration, US guided, and you try to aspirate completely and come to, and that this portion, this is very important. Take this fluid separately for cytology, and also make minimal movement to the cyst wall so that you can get good tissue for cytology. So in cyst fluid analysis, what all you do? You can do a macroscopic analysis like string sign, cytology, amylase, glucose, CA, and DNA markers like that. This is a string sign. It's a very simple test. If you have got adequate fluid, you can tend to do that. It has got a high specificity. And this is actually what we do. You can either use a needle and try to gently allow it to drip it down. And if it is extending to at least 1 centimeter, lasts for 1 second, and it's said to be a string test positive. Coming to the most commonly used and most predictive one is the Carcinogenic Antigen, and it is found to be of high value and is said to be probably the most accurate tumor marker which will differentiate between mucinous and non-mucinous one. The cutoff value usually taken is 192. But the most important thing is that if the values are much less than 5, this is specific for serous cystadenoma, pseudocyst, or cystic neuroendocrine tumor. One new thing is that actually the estimation of glucose very simple, and it may be more accurate than carcinogenic antigen, especially in mucinous cyst. And the cutoff is taken as less than 50, is suggestive of mucinous cystic neoplasm. Amylase, not much value, except if it is very low, then you can exclude it is pancreatic pseudocyst. DNA molecular markers are coming in a big way, and the KRAS and GNS mutations are found to be useful with a high specificity, but relatively low sensitivity. And the malignant potential rises the chances of getting more and more mutations of DNA in these studies. So coming up with just look at a glance of what we have looked at that. String test, it is quite specific and sensitive for detecting mucinous one. Cytology, it depends upon, because many times you may not get, but you can get a cell wall cytology, which will come to you later. And CA found to be very useful and high sensitivity and specificity, especially for mucinous cystic neoplasm. And low CA is also found to be useful, especially which I discussed when you get a serous cystadenoma or a pseudocyst, etc. And amylase low, if you can exclude pseudocyst. If glucose low, it is more in favor of mucinous. If you have got evidence, we have got facilities for DNA mutation studies, it is found to be useful in mucinous one. Mural nodule, you can detect if it is not well evident by contrast if facilities available there. Coming to needle-based confocal laser endomicroscopy, it is found to be quite sensitive and specific. Specificity is quite high. This is actually one which shows the serous cystadenoma, which shows the superficial vascular network. This actually shows a papillary projections of IPMN. Coming to needle-based microbiopsy forceps, and it is found to be quite useful. And in fact, the recent studies, systematic analysis have shown that is quite useful. And this is one of our patients which actually has shown that you can see the needle the biopsy forces coming through a needle. You do a tending sign, that is very important. Unless you get a tending sign, you may not get adequate tissue. This opens inside, it goes through a 19 gauge needle, and you take a biopsy. Pancreatoscopy, is there a role? In selected cases, yes. This is a young lady who came with the dilated main pancreatic duct, and there was the opening was suggestive of IPMN, and we did a pancreatoscopy. It's quite an old video, sorry. And we found that there are actually 3 places, biopsy was taken, 3 places to tumors, and she required a total pancreatectomy. Rarely we do come across situations like this, and we tend to do a cystoscopy. Actually, you look into the cyst cavity. And this is a serous cystadenoma, 19 gauge needle, through that a fiber is passed. And you can see the serous cystadenoma there. This is actually a mucinous cystadenoma, where we passed a needle, a fiber through the 19 gauge needle. You can see the mucinous cystic lesion there. And you can try to differentiate between these two. Coming to the mainstay, the mainstay is actually surgical resection. But the selection of this for surgery is actually quite critical and is challenging because there are many factors involved in that for selection of patients. And the surgical treatment is mainly resection, depending upon the site, either it is a Whipple resection or is a distal pancreatectomy or a central pancreatectomy, whatever it is, a median pancreatectomy. It's basically done in for patients who is symptomatic, who has evidence of malignancy, or who has got evidence of high-risk factors for malignancy. For serous adenoma, surgical resection is recommended only for symptomatic tumors, otherwise no. Mucinous cystic neoplasm considered for all patients, surgery is considered for all patients, but provided with they have got a higher risk of malignancy like symptom, nodule, and size. In IPMN, we know that there is a high risk of malignant risk, and in main duct surgery is the main duct IPM surgery is the mainstay, mixed type surgery, and branch duct IPM you have to be selective and look for a risk feature. And absolute indications are main duct more than 1 centimeter, enhancing nodule more than 5 millimeter, evidence of solid mass incytosis, presence of jaundice, cytology suspicious or positive for malignancy. Relative indications, especially for branch duct, main duct is also dilated 5 to 9 millimeter, cyst is more than 4 centimeter, enhancing nodule, growth rate more than 5 millimeter on follow-up, serum CA19 is getting elevated, history of acute pancreatitis or a presence of new onset diabetes. And SPN also, it is considered to be pre-malignant, so this has to be taken up for surgery. And there is an incidence of, the malignant chances is more than 15%, so it is generally taken up for surgery. What are the endotherapy for cystic neoplasm of pancreas? There are of those patients where surgery is not feasible, then we can consider EUS-guided ethanol ablation or pancreatitis, chemotherapy ablation or radiofrequency ablation. I'm not going to detail of this because I'm not doing it, but this is the case selection will be quite challenging in these patients, and we need to get more data on this one before we really practice this. Coming to surveillance after surgical resection of serous adenoma and mucinous adenoma, mucinous cystic neoplasm without any invasive features, surveillance is not necessary. In all other patients, we need to keep them under surveillance. There are different type of surveillance follow-up recommended in different societies. But in general, most of these patients require some sort of surveillance. And depending upon the size, the societies of different societies recommend different types of follow-up surveillance. But mostly, those patients who has got smaller lesions, they need to be initially followed up for 1 year or so, and finally then you can actually increase the interval or you can increase the period of imaging of that. AGI in fact recommended to stop surveillance after 5 years, but most of the societies do not agree with it, and most of the society, even the European society recently has said that this should be maintained lifelong. And these are the best way of imaging is MRI, if not EUS, and also do a CA19 for this patient. So just look at a patient who is coming in with a pancreatic cyst. You do an imaging, and the best imaging would be an MRI or an MRCP, with an MRCP. If that shows a high-risk stigmata, CVD is dilated, PD is dilated, there is evidence of mural nodule or solid components, and if the patient is surgically fit, straight away go for surgery. If the patient is not fit for surgery, then you can think about other options of treatment, like EUS-guided therapy. But if there is overt evidence of malignancy, then the endotherapy may not be that feasible, but RFA can help in these patients, especially when there is evidence of malignancy. But if that shows only worrisome features, that is more than 3 centimeter diameter, PD dilatation is between 5 to 9, enhancing cyst wall, and non-enhancing mural nodule, and there is a suspicious lymphadenopathy, you use EUS-FNA. And then if that fits into that of a high-risk category, the patient is taken for surgery or follow-up, if unfit, follow-up with the other modalities. If there is no high-risk strata, stigmata, or worrisome features, if the size depends upon the size of the cyst. If it is less than 1 centimeter, follow-up every 2 years. Between 1 and 2 centimeter, follow-up after 1 to 2 years. And if it is a bigger one, 2 to 3 centimeter, follow-up every 6 to 12 months. And how long to follow? It depends, but mostly it is recommended lifelong. So I would like to conclude my talk by telling that though there are different guidelines for managing cystic neoplasm, there is an individualist approach for management is essential. A good quality MRI is the best modality for diagnosing as well as identifying high-risk features. And US is recommended when there is an uncertainty in diagnosis or when there is a features of concern on imaging. Surgical resection for patients with high-risk features, and especially on follow-up if they develop high-risk features, they have to be taken up. There is an ongoing challenge to detect features predictive of malignancy. And we need high-quality studies for better diagnostic markers and tools to improve the risk stratification. Thank you so much for your kind hearing.
Thank you, sir. It was a wonderful review over the last 20 minutes. You have made it very concise and you have touched upon most of the topics, most of the diagnostic modalities and its limitations and its uses as well. Probably we have time for a couple of questions, but I'll start off with one. You said that surgical resection is a definitive treatment when the cystic neoplasms. But one common problem is when you have a main duct IPMN, which is involving the entire length of the pancreas. What would be the thing? I mean, do we go for a total pancreatectomy or is it the ripples? And sometimes the surgeons find it difficult to offer what kind of resection to do. What will be your take on that?
If the whole duct is dilated, there is a full dilatation, there is a high likelihood that the patient will end up with a total pancreatectomy. But what the surgeons do, that we also follow, that you do a frozen section at every time you after the resection. I mean, when you end up here, suppose you see the main area, you do a resection and send it for frozen section. Right. But one case I have shown you, there actually we were prepared because we did a pancreatoscopy and I have taken biopsy from 3 different areas and all were showing, 2 were showing high-grade dysplasia and 1 was showing malignancy. So in that patient, there is no doubt. But I won't recommend that everybody should do a pancreatoscopy and it is not feasible also. But what I suggest is if it is a localized dilatation, go for a resection, partial resection or a segment, I mean, depending upon the site of the pancreas, you do the resection. But always make sure that you send it for a frozen section and make sure that your resection is complete. If it is, the whole duct is dilated and if you are not able to see a tumor as such, then there is actually no opportunity that you may have to go for a total pancreatectomy. But I'm sure surgeons are better people to answer that. I'm seeing some surgeons sitting there, or someone else, Jayanti or somebody else can also comment and answer, correct me.
Any other questions? Yes.
Naresh is there. Naresh, you want to make any comment on that?
No, I think I agree entirely with your thing that of taking a frozen section, I think is really the way most people would do it.
Thank you, sir.
Matthew?
Yeah, Devi.
Yeah. Well covered, and you certainly said the importance of history. One more point I just want to tell everybody that people should take effort to find out whether the previous imaging showed any cystic lesions. If there is no cystic lesion, if it is available, and this happened after an onset of acute pancreatitis, it goes well with pseudocyst. Otherwise, if it is not typical, one should put every effort to consider these cystic lesions in their differential diagnosis, because cystic lesion can present as acute pancreatitis. Sometimes acute pancreatitis may not have features of pancreatitis, may not have features of acute presentation.
And Ravi, I would like to ask all of you, suppose you get a very, sorry, we get a very high level of amylase, 50,000. Can we just safely say it is pseudocyst?
In where? In the cyst fluid?
Cyst fluid.
See, IPMN can have a very high value of amylase.
I've seen this thing many times, and I think, CA value has to be very carefully looked for. And now we have got glucose. I think we should actually be very carefully. And there is a good study from India, Only Institute by Deepak Madhu and group. And they have done and also found that this is an extremely valuable technique, and I think we should adopt doing blood sugar also. And it is equivalent to that of CEA. And I have found that in patients who has been diagnosed as pancreatic pseudocyst with a value of more than 50,000, and finally this patient turned out to be a cystic neoplasm, and this patient underwent a cystogastroscopy, and the patient follow-up, this patient was found to have a cystic neoplasm. So I think that this is all very important, and just by looking at amylase value, we should not give any importance to that. I am seeing Satyaprakash also there.
Yeah, thank you, Matthew. It's a pleasure to watch you.
Dr. Ravi, we can move on to the next session.
Yeah, if there is no more question, I think we should move on.
Thank you so much.
Thank you, Dr. Matthew.
Thanks,
Thank you
Matthew.
very much.
Thank you.
Thanks, Dr. Zakaria, for joining the session, and Dr. Satyaprakash. Nice to see you all.
Yeah. Good evening, senior teachers, colleagues, and dear friends. It's a great privilege to be associated with this prestigious meeting of TNI ISG, the Southern ODC. It's a very unique meeting, I would say. I bring greetings from Kerala chapter of Indian Society of Gastroenterology, and we are neighbors and we have been associated together. So the next talk is on inflammatory bowel disease. And for this, we have a stalwart of gastroenterology from South India, Dr. Naresh Bhatt, who is an excellent teacher, clinician, and researcher. So without wasting much time, I would invite Dr. Naresh Bhatt to deliver his lecture. Please.
Thank you, Prakash. Am I audible at the other end?
Yeah.
Oh, yes. Yeah.
Thank you, Prakash, and thank you, Jayanti and Ubaldas and all your colleagues there at the Tamil Nadu the chapter of the ISG for initiating this meeting and having us over. I come from Karnataka, and it's.
We can't see your slides as yet, Naresh.
I have put it on.
Not yet. We can't see it.
You can't see?
Yeah.
Please share again.
I'll try and do something. No?
Not yet.
Okay, I don't know. Through here. Okay, I'll try again.
Probably can move out and come back again.
Naresh doesn't require any education on that. He is authority on Zoom now.
Yeah, we can see it now.
You can see it now?
You can see it. Put it on slideshow.
Yeah. Okay.
Yeah.
Yeah. Now it's perfect.
Now, when we talk about Karnataka and Tamil Nadu, it's often said that the Kaveri is a bone of contention, and that's where all the disputes begin, and that Kaveri divides the two states. I believe that if Kaveri was to divide the two states, the direction would be somewhere like this and not flowing downwards into Tamil Nadu. So I think the Kaveri actually unites us and enriches both the states. And today I'm going to use this theme of how my own journey over these last few decades has been enriched by friends and colleagues from Tamil Nadu, and I'm grateful to them. The invitation said that I was from the garden city of Bangalore, and this is a picture of the pretty Lal Bagh in the heart of Bangalore. And right behind that little canopy, you can see the glass house. And I believe I was the last person who got actually married in the glass house in 1979. I believe there have been no more private functions since then. So I have some kind of little thing behind my name. So let's go on to the topic first. And before that, I must pay my homage to two stalwarts of gastroenterology. One is Professor Madan Gopalan, the father figure of gastroenterology in the country, and my good friend, a gentleman and a fantastic professional, Dr. Chandra Mohan, who's a GI surgeon, and we have learned lots from them. Om Shanti. We pray for you, and I hope that you keep us in your mind from heaven and keep and bless us all the time. My story starts in the 80s when two young men, one from Tamil Nadu and the other from Karnataka, started their careers. One was the quintessential hero, debonair, good-looking, handsome guy. And the other was the anti-hero. Both continued their careers over these last 4 decades. I'm talking about Kamala Hassan and Rajnikant. And that is when I started my odyssey in IBD, and I made a presentation at PGI on a young lad who I thought was classical Crohn's disease. And I was asked very simple questions. Does Crohn's disease exist in India that you can make a clinical diagnosis? And I got lambasted for it. And enjoying my discomfort was my good, handsome friend in the audience, my batchmate from my MD and in my DM, who's remained the sort of evergreen hero, as if you may call it, just like the person to the left of the screen, while I have aged considerably. I don't know about the two actors, but TSC and me shared intense rivalry and a great friendship that goes on for these 4 decades. When I finished my DM and I came to Bangalore, I was called to a hospital where I interned, and I was asked to see twins who were 18 months old with chronic diarrhea, with mucus, some blood, their failure to thrive with clubbing. And after doing a DM in gastro, it was a simple diagnosis. In fact, I actually took a small clinic for the PGs on IBD in children. And the next day, I did a sigmoidoscopy. I didn't have a colonoscope in those days. And this is what I found. I found just hundreds and thousands of worms, pinworms coming out, mimicking IBD. And both these babies received anthelmintics and thrived thereafter. So this was the second kick up to a very prominent part of my anatomy then. And I learned that we need to deworm all our patients before we contemplate endoscopy or colonoscopy. The next few years brought more obstacles. There's some success and failure. Again, a 12-year-old boy, and for some reason, I don't know whether some of you have noticed that when you come back after a DM, it's usually the pediatricians who tend to back you rather than the adult physicians. So this was a boy who had chronic diarrhea for 3 months, weight loss, arthritis, even had a flictonular keratoconjunctivitis and an ileocolonic disease. And I said it was Crohn's. The pediatricians, however, disagreed vehemently, gave him ATT. His disease progressed. My friend, a surgeon, operated him with an ileocecal mass, and we had a big clinical meeting saying how we cured him of his Crohn's disease. Of course, there was no therapy given thereafter. He recurred. He did well with steroids twice. He had multiple surgeries done by another surgeon over 3 months for strictures and intracutaneous fistula. And this young boy, we lost him at the age of 16. So we had to convert these failures to success. And this taught me many things. One was the need to learn more about Crohn's, the need to educate our surgeons and physicians, and also project our ability that we could manage these patients better.
9 o'clock.
And of course, to get comfortable with immunomodulators, which were very important, and we had absolutely no idea of using them because our pharmacological book always put them in the chapter of anti-cancer drugs, and we were not familiar with it. Then came another Tamil Nadu connection. My good friend Sundar, who's known and related to some in the audience here, nephrologist trained at CMC, who's my colleague. And with him, I had several sessions to gain the confidence of using azathioprine. So we did many things to move from failure to some kind of success. Then came this problem of pathology and diagnosis. Brought up on the romance of Arthur Haley's final diagnosis, we always believed that the ultimate God was the pathologist, and he had to have an answer for all our problems. But then we were confronted only with reports saying chronic colitis, non-specific colitis, chronic inflammation, and so on and so forth. And then we realized that they are having a problem. Initially, we blamed them, but then realized that like Google Maps, they can only show you the way. You have to decide the destination. So I learned to embrace their imperfections, though they could only tell us that much. They couldn't tell us more than what they could see. But we realized that IBD is a chronic disease and that the diagnosis should be based on facts, that it should show you chronicity, should not show pathognomonic features of any other disease, and should be compatible with the clinical, endoscopic, and radiological features of IBD. And of course, we needed to be careful about mimics. Beauchamp, in one of his presentations, made a very clear distinction between what is chronic mucosal inflammation, that is infiltration of chronic inflammatory cells, versus chronicity in the tissue, which is manifest by structural changes like crypt distortion, basal lymphoplasmacytosis, and metaplasia. So to the youngsters, a big message here is don't look at the cells, but look at what is happening to the tissue overall. If you have chronicity, yes, you're one step closer to a diagnosis of IBD. Then you have the big five, the differential diagnosis. You have ischemia, drugs, solitary ulcer syndrome, segmental colitis associated diverticulosis, TB, and lymphoma. So these are some things that you would have to be careful about, because this is where we make mistakes often. And here we have the big five of the gastroenterology in Chennai. My good friend Palliswamy, who has also got a Karnataka connection in that he studied in Karnataka. And I believe that the first sentence that he ever spoke to me when we met in a meeting in Chennai, he just walked up to me and spoke to me in Kannada and said, "Hege idira." And that's sort of made a very strong bond, which goes on over these last 30, 35 years. And we've had great times together. Thank you, Palli. And of course, we have our mentors, starting with Dr. Bala, Colonel Krishnan, my good friend Ashok Chako, and of course ATM, whose friendship goes on actually beyond 4 decades. Thank you, all of you, for your mentorship, your friendship, and all the help that you have given me, some of which I can't tell in a forum like this. So what are the mimics? We all know about TB. We've had amoebic colitis, mimic being called IBD. We've had lymphomas, I've discussed with that. Do look at the images here. We've had women with endometriosis who are masquerading as IBD. In fact, I had a 38-year-old lady who was in the United States being seen by a very prominent IBD specialist for 6 years on treatment for IBD. And when she came to India and was inquiring whether biologics were available, we actually changed her diagnosis to endometriosis, and she's done extremely well thereafter. So beware of these mimics, because these are the ones that are going to crop up once in a way and ruin your sleep. We've been hearing about conversions in Tamil Nadu in the TV of late. And so we've been doing some conversions in Karnataka as well. And that is converting general pathologists to GI pathologists. How did we do that? First, we went and sat with them and looked into the microscope yourself. And that's the best way to put pressure on a pathologist. So once you learn, you get comfortable, get them involved in the decision-making process. Then they feel they're responsible for their diagnosis. And believe me, they'll improve within 6 months. And this way, I've been able to create 4 GI pathologists very comfortable in IBD over the years in Bangalore. You have a picture of someone there. I'm not sure whether you see him well. I think the other images are covering him. Is a very, very good friend of mine who actually speaks very little. One day I asked him, I said, you're from an institution that has got a great pathology department, and I'm sure you don't have the problems that we face as far as pathology is concerned. I said, how do you manage? You're so lucky. He made a very cryptic remark. He said, they write what they want, but we decide how we go to treat them. And believe me, Rama, that was the best statement you could make to me that could ratify my decision-making process and give me enormous confidence that we could make a diagnosis based on our own skills and all the information that we have, rather than look at the diagnosis the pathologist makes. Moving on to pathology, went into radiology. And I've had the luck of being in numerous sessions on workshops, guidelines, expert committees, and so on and so forth. Let me tell you, expert committee is not a committee of experts. Expert committee is a group of people who are also learners, who go sit down, learn from each other, and then come out with one statement. So we all go there to learn, we discuss, and in the process, we also meet up old friends. You see the 2 high priestesses of gastroenterology, adult gastroenterology and pediatric gastroenterology in Chennai, and remain good friends. And I put their pictures together because you always see them together. Now, what did this meeting achieve? Now, this meeting achieved something that changed our practice. And we made small bowel imaging an integral part of all our IBD patients, especially Crohn's. And you see the kind of information that it gives you and makes so much, things so much easier. You find multiple levels of involvement, you find long strictures, the diagnosis of Crohn's becomes more likely. You find the comb sign, then you realize that you're more likely to be failing Crohn's. You find a lot of lymph nodes, then you know something else is amiss. And of course, the use of the CT scan of the chest, which helps you, one, to see if there is tuberculosis, whether it's before biologicals or even when you have a difficult case of Crohn's versus TB. So this was a kind of a landmark session that we had, which changed our practice. And now this is integral to our practice in my hospital. The other thing that I have learned over the decades is that not all specialties are comfortable in IBD because they often don't see these kind of patients. And hence, I've had patients who've had an erythema nodosum undergoing an IND. I had flictonular keratoconjunctivitis called viral conjunctivitis several times. I've had a patient of mine with ulcerative colitis being treated for a seizure disorder when she had a venous sinus thrombosis. We've had patients diagnosed with vitamin deficiency when they have oral manifestation of Crohn's. Someone managed as eczema when they have a pyodoma gangrenosum. And this hairy gentleman had 3 surgeries for pilonidal sinus before he came to us, and we diagnosed that he actually had Crohn's with a tract that was going superiorly. So it's important that as gastroenterologists and IBD clinicians, we need to be comfortable diagnosing these ourselves and encouraging our colleagues to get better. It's only when we do this that we are going to get better things out of them. The other thing that I learned and was of drug therapy, and I owe this again from the meeting that Palniswamy and Bala and Ashok Chako held with Rama, of course, in Chennai, about how you need to use your drugs more effectively. You have all these algorithms which tell you, which define what the disease is. And then the therapy is decided depending on what we are seeing there. So it's important that you define the disease, the severity and extent, identify other contributory factors, and then the patient factors and preferences, and then plan out therapy. For example, for a long time, we treated ulcerative proctitis with mesalamine tablets. And look at this data, very clearly shows that suppositories are far more superior. So depending on where the disease is, we need to tailor the mode of therapy or the choice of therapy accordingly. So we know about all these, that we need to treat early, treat efficiently, treat safely, treat to target, and so on. But in India and in South India, we realize that this is not always possible. We just can't always give the patient the standard of care. The best thing is beyond their reach. So what do? You have to use what you have and do what you can. And I've listed out certain things which are what I call the next best options, which we need to familiarize ourselves. And that is what we did. And we use it in difficult situations. For example, use of methotrexate instead of azathioprine in patients with Crohn's. The use of tacrolimus instead of azathioprine in some patients. Use of fecal microbiota transplant in difficult, more refractory patients with ulcerative colitis. Exclusive enteral nutrition, again, is something we have learned from some of our younger colleagues, that we could use this very effectively. And of course, even short-term biologics, I'll talk about this later too. So just because we can't do the best, there's no need to put our hands up and walk away. We can do the next best and certainly help our patients in some way or the other. This is a favorite trial of mine, called the STORY trial, which tells us that in patients who received infliximab for a year and with an antibiotic and were in a remission for at least 6 months and they discontinued, not everyone relapses. About only 44% relapse. It means over 50% stay in a remission. So just because you had to pull out the infliximab because of whatever reasons, it's not the end of the world. A lot of them still do well. And do well, if you can reintroduce after some time, they still do well. So things are not as bleak as some of the data that comes from the studies actually tell us. They are a little more biased, and I think we need to read between the lines and look for these positive stories that come from trials like this. The next issue is between the physician and the surgeon, a time-honored problem. We were told that surgery is the last option in Crohn's and UC, and a good physician keeps the surgeon at bay. To an extent, it is true. There's no doubt about it that your aim of therapy goal is to keep in what steroid-free remission, surgery-free remission, and so on and so forth. That's good. But we have misinterpreted that as saying that surgery should never be done. And after 30 years, I can philosophize and say it should never be a turf war. Surgeons are much better in some aspects of IBD. Resection or surgery does not mean that you have failed. It just means that the disease has won and you need help. And surgery is settled and useful option in IBD in select situations. So what do? We use these handsome guys. You see on the top thing, the physician is there, but the more handsome looking guy is a surgeon, and it's always so. And you have this gentleman at the bottom of my slide, the handsome person who put South India on the map of endoscopy by his pioneering work. And my salute to you, sir, for doing that and being such a mentor to all of us. And what we need to do for these surgeons is involve them in discussions, even in routine cases. Always use their help in perianal problems, fistula, abscess, and so on, which they are so good at managing. I always use them to help me out in my sick patients in decision-taking or patients who have malnourished, and sometimes even at looking at the radiology, because in some areas they definitely are much better than us. This is again a very favorite trial of mine called the Lyric trial, where they took patients with Crohn's disease who were in the terminal ileum, who had not responded to steroids or immunomodulator therapy, but they were not obstructed, and they were being considered for biologics. So they randomized them into two groups, the one who had a lap ileocolic resection and a group who had infliximab. And see what they found, that the ones who had a resection actually over a long follow-up of up to 10 years did much better, did not need infliximab at all, right? Which means that selective surgery, even in non-obstructive situations, can have great sort of rewards. And we've been doing this routinely now. When you have localized disease, or we don't have a great confirmation of Crohn's on the histology for whatever reason, or our scope can't reach up to that place, or we are considering biologics, we offer them a limited resection. We get an accurate diagnosis, much cheaper because you sort of save biologics in a lot many cases or delay it. And of course, we keep them on immunomodulators as a follow-up. So surgeons remain our good friends. Next is a story again of a 12-year-old boy who had Crohn's disease. We induced him into remission with EN. This EN I learned from a young pediatric gastroenterologist who was nice enough to educate us about EN. We started our usual azathioprine low and slow, but at 75 mg dose, which is just a little over 1.5 mg per kg, he started having intolerance with nausea, vomiting. So I said, what now? Do we put him on biologics? What else do we do? And that is when I realized that it's good having a lot of young brains around you. You know what is gray hair? Gray hair is where all your gray matter is leaked out. It's good to have these youngsters around to help you take decisions. And what did we do? We, based on the recommendations of my young colleagues, we decided to get their metabolite levels, and we look at the 6 TG in this kid, even with 50 mg of AZA, which is just a little more than 1 mg per kg, we had good therapeutic levels. So we just continued that, and he's continued to do well. So I think the message here is that we need to embrace new technology, use it in difficult situations. You may not use it all. And certainly when you're using thiopurines and infliximab, these kind of therapeutic drug monitoring does come in useful. Coming to the last couple of issues, one is the point of care testing. And we've been influenced by this young man at the bottom of your slide there, who's been very proactive in embracing new technology, new things. He's always the first to use some thing. Not only is he smart, but he does it effectively. And point of care testing is that way. So in our practice, we do a fecal calprotectin routinely, and we do it with a simple app that is done in the department, works out much cheaper, done by a technician, takes a few minutes, and it's just using an app on the phone. Similarly, we use CRP and bowel ultrasound routinely. And as I said, bowel ultrasound is an excellent modality, which we do in the unit, where we look at the thickness of the bowel before therapy, when we use a follow-up, so that we save a lot of money and radiation for these patients, and we are able to follow them up. Here you can even make out the disease activity with the kind of Doppler signals there in the wall. And the two people that you see in this picture are Dr. Kyle and Pradeep, who are again both from Tamil Nadu and have been in Karnataka, and that's their connection. And they are the ones who have been trained in bowel ultrasound and helping us, thereby showing how Tamil Nadu also indirectly enriches my practice in IBD. So over the years, we have realized that it's not just patient feeling better and symptomatic response. We need to go into remissions and decrease in what are markers, endoscopic healing, and finally, target on the long term is a kind of histological remission. This is what we're striving to, and I'm sure we'll get there with the help of all these youngsters. So I've tried to put forward the challenges of a beginner, the obstacles, the successes and the failures, the problems of pathology and how we need to utilize our own strengths. Radiology and the surgeon, both of them are extremely important. Innovations and technology, and finally, striding confidently towards new goals. Thank you, and thank you, friends, for being a part of my professional career and my life over these last 35, 40 years. Thank you.
Thank you, sir. Thank you for taking us through a journey through IBD. It was really an odyssey. So, as you said, initially the issue was with the diagnosis, especially regarding Crohn's disease, and many people, I remember even in the early 2000s, people were not willing to believe that Crohn's disease did exist in India, especially from North India. So now things have changed. We are now into therapeutic strategies and how we can benefit these patients. I think we are running short of time. If we have some pressing questions, we can take it up, maybe one or two. There was one in the chat box that was regarding MMF in Crohn's disease. Is there any data? Because there may be some patients who may be having intolerance to azathioprine, and then they may not be able to afford biologicals. Do we have any alternative for these patients?
MMF we have not used much in Crohn's disease. We have used methotrexate. MMF we have used in more in ulcerative colitis. The problem with MMF, of course, is the fact that it tends to cause diarrhea. So that becomes a bit of a challenge. So I have not seen any very strong data on MMF, but I guess if you're cornered, I think you must get comfortable with these drugs and use them.
Dr. Satyaprakash? Dr. Satyaprakash would like to say a few words.
Yes. Yes, Jayanti, I think it's a pleasure to watch Naresh speak in his own usual style. And he intelligently put and covered all the elite gastroenterology colleagues from Tamil Nadu into the IBD forum. And we are glad that we both made a beginning of medicine and gastroenterology from PGI Chandigarh, and we had 3-4 decades of friendship and then studied together. And we are really glad in Bangalore that he's a pioneer in IBD clinical study, and first to start FMT, EN, and bowel ultrasound. Very nice, and he very intelligently put all the problems into case profiles, and then he highlighted all the problems. Thank you, Naresh. It's a pleasure again to watch you.
Thank you, Satya. I mean, you and TSC, we've all grown up together over these 40 years, 42 years. So it's a long time that we've been.
Yes.
Dr. Naresh, you have a good friend, Dr. G.V. Rao here.
Oh, GV is here?
Yeah, GV is here. Dr. GV can comment on the surgery. He discussed you're a very good friend of his.
Phenomenal talk, Naresh. Phenomenal talk. The words of wisdom, actually, I just sent a text to you. Phenomenal topic. We enjoyed your talk thoroughly.
Thank you. You've been
Actually, over a period of time, actually, all of us seem to learn a lot of things beyond the text, actually. Phenomenal talk, Naresh.
Thank you, GV. Thank you. Thank you, GV.
Thank you.
Thank you, Jayanti, for this opportunity.
Thank you. Thank you so much.
Giving
I
non-scientific talk.
Yeah, I remember the airport, airport days when we were thinking of this ODC. Thank you so much. Thank you.
Thank you. Thank you for having me. Bye-bye. Good night.
Thank
you. Ruben?
Ramas, any thoughts about the limited resection he is talking about in the Crohn's disease versus biologicals in Indian settings?
There's some question to Naresh.
I think what Dr. Ubal was asking was about limited resection. Certainly, I think there's a role for early surgery in some patients, and now there is a tendency to, in isolated ileal disease, to do surgery. And as Naresh showed in the LYRIC trial, that they can be maintained well thereafter with immunomodulators or biologics.
Madam, you are muted.
Request Dr. Wadhwa and Dr. LBK to take over for the debate.
Yeah. I think after a very thought-provoking talk from Dr. Naresh, but as as is his habit now, giving a very, very interesting talk, we move on to the next topic on portal hypertension, and especially the prevention of the progression of the disease or primary prophylaxis of varicose bleed, or to prevent the decompensation in this. And we have two very young, enthusiastic gastroenterologists with us, Dr. Chalapati Rao and Dr. Hemamala, who will talk about the positives and negatives of beta blockers and endoscopic varicose ligation. I would request Dr. Chalapati Rao to start the debate by speaking on the benefits, disadvantages, and the role of endoscopic varicose ligation in the primary prophylaxis.
So good evening, everybody. So thank you, Tamil Nadu ISG chapter, for giving me this opportunity. So my topic is to talk about endoscopic varicose ligation, especially the role of this varicose ligation as a primary prophylactic method to prevent the bleed and other complications in large esophageal varices. So if you see the esophageal varices in portal hypertension, we can see in up to 40% of patients with child A cirrhosis. These varices can be seen in up to 60 to 80% in child C cirrhosis. If you see the yearly risk of progression, new varices are seen in up to 8% every year, and they progress from small to large in up to 8%, and they can bleed in up to 5 to 15% every year, and it can carry a mortality of 20%. So if you see the algorithm of management of varices, the role of non-selective beta blockers, it comes in patients with Medium to large varices which are at high risk of bleeding, that is carrying red whale signs especially, we can choose between the varicose band ligation and non-selective beta blockers. So typically primary prophylaxis is offered for patients who have medium to large varices or small varices with red whale signs, and those with decompensated cirrhosis having small varices. And the advantage of EVL is that it can be done in the same session while doing an index endoscopy with fewer contraindications than beta blockers. And especially it is practiced in patients with medium to large varices. If you see the role of these various treatments in prevention of the first varicose bleed compared to the untreated patients, beta blockers and band ligation has a better advantage. Coming to band ligation, it prevents the first varicose bleed in up to 90% with number needed to treat of 4. And in beta blockers, the first varicose bleed can happen in 17% and number needed to treat is around 11. So this meta-analysis in 2010 shows that beta blockers are better than, varicose band ligation is better than beta blockers. And if you see the majority of studies across a decade, majority of studies, that is RCTs, which compared between beta blockers and EVL, majority of them, they are underpowered. They are, the N value ranges between 24 to 152 patients. The follow-up ranged up to 11 to 55 months. And the sicker group, that is a child C, they are included only in 13 to 33% of times, and alcohol is the predominant etiology, making it that we cannot generalize in all group of patients. Few meta-analyses showed that EVL is better than beta blockers as primary prophylactic method in 2012 and 2010. 2010, beta blockers are shown to have higher mortality and higher bleedings in esophageal varices compared to band ligation. And if you see only high quality trials, bleeding is less compared when EVL is offered compared to beta blockers. And another meta-analysis from Cochrane in 2012 has shown that EVL decreases the risk of varicose bleeding 13% versus 19%, and EVL decreases the risk of overall upper GI bleeding 14% versus 20%. And one of the recent meta-analysis in 2021, including 66 RCTs, could not conclude anything. The evidence indicates considerable uncertainty about the effect of beta blockers versus band ligation on varicose bleeding. People talk about the adverse events related to band ligation. Perforations are reported, but only in one case when the old overtubes were used. And now we have better multi-band ligators and banding techniques have improved, making it much safer. Pathophysiologically, it acts by producing ulcers and causes healing of the varices. Ulcer-related bleeds are reported in up to 3.6% of patients after EVL, but majority of times they can be controlled by endoscopy. So beta blockers are considered as aspirin for hepatologists, but there are a lot of limitations. It needs to be given for lifelong, and when you stop, there is a risk of rebound bleeding because of rebound hypertension, portal hypertension. We need to frequently adjust the doses, and patients have to be on strict follow-up. And we know that treatment has to be withdrawn in up to 15% of patients because of various reasons. And not all patients respond to beta blockers. Only 30 to 50% of patients achieve the desired reduction of HVPG. And more commonly, we frequently monitor this heart rate in our OPDs and clinics, but studies doesn't show any correlation with reduction of HVPG, which is a more objective parameter. And monitoring of HVPG to direct the therapy of beta blockers is hard to obtain, and only very few centers in the country actually practice it. So how long to use beta blockers? It's actually a lifelong commitment. And when you withdraw the beta blockers, there is risk of bleeding similar to the untreated group again. So the risk again bounces back to untreated group. And also there is increased risk of mortality after stopping beta blockers. And so it has to be continued indefinitely. And also it is not free of adverse events. Many adverse events are reported in various trials. Fatigue is a big problem in up to 21%. Hypertension is a big problem, requiring frequent OPD and hospital visits. Up to 15% of patients, we need to titrate the dose, give IV fluids, admit these patients. And other side effects like dyspnea, nausea, dizziness, sleep disorders, and impotence have also been reported. So compared to band ligation, the adverse events are more frequent in beta blocker group. The risk of first varicose bleeding actually depends on HVPG response. So those patients with who doesn't have this HVPG response have higher risk of bleeding. And those patients where HVPG is decreased more than 20% from baseline, which is achieved in 30% of patients, the risk of bleeding is less than 10%, and the risk of bleeding is virtually zero if HVPG is decreased to less than 12 mmHg, but it is achieved in only 20% of patients. And beta blocker non-responders have higher risk of bleeding. Non-responders in this particular study in 2006 is up to 65%. And in this group, 45% of patients can have a risk of bleed at 8 years. And those who respond actually had a better chance of getting control and remaining free of bleeding. Compared to the cost effectiveness and quality of life using Markov decision model, if we consider the quality adjusted life years, EVL is found to be cost effective than beta blockers. And if you compare the cumulative direct costs of both beta blockers and EVL, they were shown to be similar in the Gastro paper in 2005. And patient preference, actually, if it is taken into account, patients prefer to have EVL, which is a surrogate marker of quality of life, as shown in this 2004 study from Shefki et al. We frequently monitor this heart rate each and every time the patient visits the hospital and clinics, but it has a very poor correlation with HVPG. As shown in this study in 2013, the target rate achieved, the target heart rate achieved was similar between the HVPG beta blocker responders and non-responders, 36% versus 36%. And the change in heart rate is also similar between responders and non-responders. So you actually can't say that if you see the heart rate is less than 55 to 60 beats per minute, you can't say that they're actually responding if you actually correlate it to the HVPG values. So who should decide about the treatment? Is it the patient or the doctor about beta blockers or EVL? Majority of times, it's the physician who decides and imposes the decision on the patient. But this interesting study, wherein a questionnaire is provided to 53 patients and 61 providers, wherein it is shown that 64% of times these patients prefer to have EVL over the beta blockers. And in fact, physicians also, 57% of times they prefer band ligation over beta blockers. This study is done in 17 centers where EVL is not the preferred modality for primary prophylaxis. So the factors which were considered before this decision making were side effects of beta blockers like dyspnea, hypotension, fatigue, impotency, and also procedure-related bleeding pertaining to EVL. So if you see the preferences, both the patient and provider says that they prefer to have EVL. And the big debate about the decompensated cirrhosis and refractory ascites, we came to know about this concept in 2010 when it was shown that these decompensated cirrhosis patients, when they're actually getting the beta blocker, they fare poor. They have a lower survival of 5 months compared to 20 months in patients who are not taking beta blockers. So 1 year survival probability, those who are not taking beta blockers survive at 64% versus 19% those who are taking beta blockers. So this opened up a concept of, the window period theory, that is in all stages of cirrhosis, we can't use beta blockers. There is a narrow window when to start beta blocker and when to stop beta blocker. The cardiac reserve in these patients actually drop down as the disease progresses from decompensated to end-stage cirrhosis with refractory ascites, hepatorenal syndrome, and hyponatremia. And during this stage, the sympathetic nervous system, renin-angiotensin system actually overshoots, and it causes more gut translocation of bacteria and increases the mortality. So again, this is also supported by one of the recent studies in 2020. It says that non-selective beta blockers actually impairs the global circulatory homeostasis. As the disease progresses from ascites-free to diuretic responsive ascites to refractory ascites, the beta blockers actually impair the cardiac contractility more and also impairs the renal perfusion pressure more, and it actually can be detrimental. So they conclude that non-selective beta blockers, it blunts the sympathetic overdrive on cardiac function. It can hamper the cardiac output. It lowers the renal perfusion pressure below the critical threshold, and it impairs the renal function. And beta blockade should be cautious, be used or even avoided in patients with refractory ascites. So when to use EVL as primary prophylaxis? Because beta blockers, the patients can be non-compliant in 10% of patients. They can cause severe side effects in 10 to 20% of cases. Beta blockers are contraindicated in 15% of patients, and they are non-responsive in 40% of patients. So in almost 70 to 80% of scenario, that EVL is the preferred modality over beta blockers. And the debate is on about decompensated cirrhosis and refractory ascites, and we need to consider the quality of life and also patient preference. So to summarize, EVL actually decreases the risk of varicose bleeding. There are many issues with beta blockers like non-compliance, non-responsiveness, side effects, and rebound portal hypertension. And beta blockers may impact the survival in end-stage cirrhosis with refractory ascites. There should be an individualized approaches, and patient preferences need to be considered. And based on these data, we should whether we should still use beta blockers as first-line therapy is debatable. And we don't need to be a wizard to practice EVL. Thank you so much.
Dr. Chalapati Rao, you mentioned more about the effectiveness or not effectiveness of beta blockers.
Yeah.
The one statement you made was post-EVL bleeding. You said
Yes.
it is about 3.6%, but we know when the patient is in child C and they have a post-EVL bleeding, what do you think the mortality could be?
Yeah, so the mortality can be up to 2%, as in as compared to the primary bleeds. The post-EVL ulcers can cause the bleed up to 50%.
Yeah,
But
that's 50%.
yeah, almost 50%, as per one of the Indian trials. But there are also categories of these ulcer bleeds, type A, B, C, like that. So especially this mortality is more in type A, that is ulcer with spurting.
Spotting, yeah. The second thing about the beta blockers being used in decompensation
LBK,
is
I
not.
think Hema has to give a talk, so you can take up the questions later.
Okay, sure.
Yeah. Dr. Hema? Share your slides.
Slides are visible, ma'am.
Yeah, put it on slideshow. Yeah, you can start.
I thank ISG and Southern ODC for giving me this opportunity to talk on this debate on primary prophylaxis of esophageal varices. Thank you, Chalapati. So because you've already given an introduction on some of the initial slides, I can skip it. So I will skip my initial slides on the natural history, what is the risk of progression, how many are going to bleed, and the predictors of first varicose bleeding. So I will skip all of these slides. So I will go straight to the point. So why are we worried about varicose bleeding? So we know that varicose bleeding is a defining decompensation event, and it is associated with increased mortality. So
Pooja, can you please mute your...
So this mortality is what we are worried, and that is why this prophylaxis concept came. This mortality was very high in the initial 80s, but over the next 2 decades, it has come down. So the mortality, like in the early 80s, the survival, 30-day survival was only 50%, whereas in the late 2000, almost 85% survived. And if you look at this survival in child A or B, so it was only 67% in the 80s, whereas almost most of them went home in the late 2000. And if you look at child C, in them, the prognosis is still bad, around 20 to 30% mortality is there. So what was this improvement in mortality from varicose bleeding due to? So this was due to band ligation, this was due to antibiotic prophylaxis and the use of vasoconstrictor. So when the thought process about prophylaxis about varicose bleed comes in, so the beta blockers were first considered because it reduces the portal hypertension. So that directly affects the primary pathophysiological mechanism in the portal hypertension. So the initial study on the secondary prophylaxis came in 1981 in NEJM. And once that showed that there is a reduction in mortality and also an improvement in the long-term survival, then came the concept of primary prophylaxis. So that means why not use beta blockers in a patient with esophageal varices, and will that prevent bleeding? So the first RCT was published in NEJM in 1987, and that showed that the patients at the end of 2 years, 74% in the beta blocker group were free of bleeding, whereas it was only 39% in the placebo. And also the 2-year survival was higher. So this established the fact that the beta blockers are effective in the prevention of bleeding in a patient with esophageal varices. So multiple RCTs came up, and then meta-analysis came up. So in 90s, the primary prophylaxis with beta blockers has been recommended. At the same time, only the sclerotherapy and the band ligation started. And with the increasing use of band ligation, it was found to be a very good in secondary prophylaxis. Then came the concept of why not use it as a primary prophylaxis? Yes, it is definitely much better than placebo band ligation. Yes, then why not compare beta blockers and the band ligation? So one of the first initial RCTs was published in NEJM by Sarin, and it was about 40 and 45 patients in each group. And if you look at the first line, it is very dramatic. So the bleeding in the propranolol group was around 43%, and in the EVL only 15%. So though this is very dramatic, if we read further, it says that 3 of the 4 patients in the ligation group bled within the 6 weeks. That means in the immediate post-banding period, about 3 of the 4 patients bled, and ulcers were also noted. And the severity of bleeding were similar in both groups. Even though the bleeding was decreased in the EVL group, there is no difference in the mortality in either of the groups, and the varices also recurred in around 20%. So multiple RCTs were done, and then came the meta-analysis. So how does the beta blocker act? So one, it acts on the beta-1 receptors, decreases the cardiac output. It acts on the beta-2 receptors, so there is flattening vasoconstriction. So both of them will decrease the portal pressure. So the portal pressure determines the esophageal varices. And then now we have carvedilol also, which acts on the intrahepatic vascular resistance, which reduces the HEPG further. So after multiple RCTs, then came multiple meta-analysis. So from 2005 to 2012 or 14, around 5 meta-analysis were published. Most of them gave almost a similar results. So this is one from 2007, about 1,000 odd patients. So what they say, band ligation and beta blockers both can be used as a primary prophylaxis. So yes, EVL definitely reduces the bleeding, but then there were lots of trials with bias. So what kind of bias? So the number needed to treat, that was not enough. So, and most of the trials were presented as abstract, where very few trials were with full papers. So after all these meta-analysis, the final conclusion both in all of them were mostly like both EVL and beta blockers can be used as primary prophylaxis. And this one was shown by Chalapathy. So I will go through this graph which he had shown. So he had shown here that when you look at all the trial, there is definitely significant drop in bleeding episodes when you use band ligation, but there is no difference in mortality. But if you look at the high quality trials, there is not much difference in the bleeding or in the mortality. So now all these meta-analysis, almost similar conclusion. So current evidence is insufficient to recommend one over the another. There's another Cochrane review in 2012, same opinion. So based on all these only, we have this IASLD guidelines or other guidelines from other societies. So either the traditional beta blockers or carvedilol or EVL is recommended for the prevention of first varicose hemorrhage. and choice of treatment should be based on patient preference and characteristics. So this is what we have. And this is our latest ISG guidelines also, wherein it says you can use beta blockers for small risk varices, and also either beta blockers or EVL, both with a strong recommendation. So now what do we do? So like the meta-analysis is not really giving us an answer. So how do we choose? So the main reason for choosing beta blockers would be the way it targets the main pathophysiological mechanism of portal hypertension. So we know that portal hypertension is because of the increased pancreatic vasodilatation and increased portal venous flow, as well as the intrahepatic resistance. So the beta blockers target all these. So if you take propranolol or carvedilol, it decreases the cardiac output, and then it causes flank vasoconstriction, so the portal blood flow is decreased, and the carvedilol acts at the intrahepatic resistance. So all the three mechanisms, that means it decreases the portal pressure, so that leads to a decrease in the bleeding. And then HCPG was also discussed quite a lot by Chalapati. So it is used for prediction and also for the prognosis of bleeding. So we know that if the HCPG reduces to less than 12 or more than 20%, the risk of bleeding is less. And also it reduces if the reduction is more than 20%, the mortality is decreased. Now, this is not freely available to everybody. So we know that if a patient responds, it shows a good response to HCPG by beta blockers, he is going to respond well. And with beta blockers, the response is probably around 35 to 40%, but then with carvedilol, this response is much higher. That means more than 50% of patients who are primarily non-responsive to propranolol will respond to carvedilol. And the HCPG response decrease is also much higher. So we have a much better drug. So now we have multiple RCTs comparing carvedilol with varicose ligation. And there is a meta-analysis also. And this shows, this was published more recently. This shows that the bleeding episodes are less with carvedilol. The mortality difference is not there. They are both equal. Okay, so now we have this good review about the use of beta blockers in cirrhosis. So the beta blockers has its very good days, then it went down, and then it is coming back. So you have to use it at the correct time. So when you look at the indications for beta blockers in cirrhosis, so there is no role in pre-primary prophylaxis. It has a role in prevention of decompensation. So the Pre-Disease trial, which was published 2 years back, it looked at using beta blockers in patients with clinically significant portal hypertension. And the good thing which they found was that the incidence of ascites was much less in patients who are using beta blockers. And then in prevention of first variceal bleeding, definitely grade 1 and level 1A indication is there. Prevention of variceal bleeding, definitely it is there. So beta blockers can be used in these multiple stages. Other benefits of beta blockers. So as I told you, it decreases the incidence of new onset ascites in compensated cirrhosis. It probably decreases SBP by increasing the intestinal motility and decreasing bacterial translocation. It's definitely much easy to use. It is cost effective also. Now, what are the problems with varicose ligation? So one, the primary reason is that it does not address the pathophysiology, that is the portal hypertension. You can block the varices, but the portal hypertension is going to be there. The cost involved. So how many times are you going to scope a patient? You're going to do it every 2 weeks, and then again at 3 months, and then yearly. How many times are you going to scope him? And then there is definitely a risk, recurrence of varices around 15 to 20%. And we are all worried about the banding ulcer induced bleeding. It is not very common, but I'm sure all of us would have seen at least one catastrophic event when the patient died out of post-varicose banding ulcer. There is no expertise needed for varicose ligation in the present days, but these are the issues which we need to think of. Is there any problem with beta blockers? Yes. So about 15% of patients have contraindications. So they may have AV blocks, they may have bronchospasm. About 15% may develop intolerance. So in many of the studies, they have said the side effects, adverse effects are more common with beta blockers. But if you look at the adverse effects, they are all usually mild or non-severe and non-fatal. So like hypotension, tiredness, impotence, and all of these are reversible. And of course, it has to be used in caution with refractory ascites, AKI, hyponatremia. These are things which we need to keep in mind. And this predecessor trial I already mentioned, wherein propranolol or carvedilol was used in patients clinically significant portal hypertension, and at the end of 2 years, the incidence of ascites was much less in patients who were on propranolol. So now, all these guidelines were not giving us very definite guidelines, but then now we have this Babeno 7, which was published recently 2-3 weeks back. So this is what it says. The prevention of decompensation is relevant in compensated patients with clinically significant portal hypertension and or esophageal varices due to their high risk of developing. So that means prevention of decompensation is our aim when we see a patient with cirrhosis. And the events that define decompensation is ascites, encephalopathy, or varicose bleeding. And treatment with non-selective beta blockers should be considered for the prevention of decompensation in patients with clinically significant portal hypertension. And the drug which is now preferred is carvedilol because it is more effective in reducing HVPG, and it has a greater benefit to prevent decompensation. So this is what the latest Babeno 7 says. So when we see a patient with varices which needs prophylaxis, I would say beta blockers remains the primary modality of prevention if there are no contraindications or if there is no intolerance to the beta blockers. It is easy and it is cost effective. Band ligation can be offered to those who have contraindications or intolerance to beta blockers. So I think this photo here sums it all. So if she is going to keep blowing into it, this is definitely going to burst. Even if you're going to tie it here, if she continues to blow into it, it is definitely going to increase in size.
Thank you, Hema. Dr. LBK and Dr. Wadhwa, a few comments and then we can conclude the session.
And thank you, Dr. Hemamala, for that wonderful lecture on the use of beta blockers in the primary prevention of the bleeding. I would offer Dr. Chalapathy to give any counter argument if they would like to have, then we will go on to have a closing comments onto it. Dr. Chalapathy, please.
Yeah, so thank you, Dr. Hema, for the excellent overview. And I do agree that band ligation has its own problems, especially the cost and the complications, especially when it bleeds. But it can be managed as effectively as the primary problem. The only thing is about probably we need to say that in some patients we need to combine both, especially that we non-selective beta blockers plus band ligation. That is number one. Number two is there are significant proportion of patients who remain intolerant or they don't respond. And availability of HVPG is actually a big problem across the globe, right? So what we are thinking that they are responding may not be responding actually. At least 40 to 50% they may not be responding. We may be just giving beta blockers and just leaving it to their fate. I do agree that beta blockers do target the primary pathophysiology, but coming to the prevention of the bleeding as primary prophylaxis, I think both have a role, and in we need to individualize the treatment for the patient, especially in those who are intolerant or those who have side effects of beta blockers. We know we need to consider band ligation as a primary modality. Yeah.
Thank you, Dr. Chalapathy. I think now we can open up the discussion for a few questions, and then we will sum up and close the thing for the next lecture. Dr. Setu Babu wants to ask a question. Sir, please.
I think both of them are dwelling one very important point is one is preventing the bleed and preventing the rebleed. And Chalapathy has suddenly agreed that, okay, both the drugs have some role. And the point is, two important points. When you see a large varix, the patient is not bothered, you are worried. This fellow is likely to bleed down the line. And you're not very comfortable to just put him on beta blocker and just wait and watch. People like Chalapathy, they say, I think I can do 3 or 4 sittings. I can eradicate the varices. I think the right word used is eradication. And then you could go on maintenance beta blocker. That's a beautiful understanding that most of us have. Because except when you talk about gastric varices, story is different. For example, when you have a portal hypertensive gastropathy, story is different. In fact, you don't want to touch, though somebody will do multiple bandings there and all those things. I think the understanding would be that yes, majority of the varices do require a banding, prophylactic or following pus bleed, and they could be maintained on beta blockers. One small last word is, there is some role of statin which we have not explored. I think simvastatin specifically, not the other statins, have some interesting role, but for their small neurotoxicity, which is so rare, I think statins have a major interesting role because they're anti-fibrotic and even prevents HCC. So I think if you can combine beta blocker and statin, that would be a better model following an eradication of varix.
Thank you, Dr. Sethubabu, for this.
Thank you, Dr.
Dr. LVK. Dr. LVK, final comments. And then...
Yeah, I think both of them have put their arguments very well. I do agree that ultimately it will end up that we have to probably do a endoscopic varicose ligation and continue with the beta blockers, because EVL does not really address the problem of portal hypertension. One of the studies which I want to bring in to even Dr. Hema showed is that in that particular study where Jamie Bosch and Diogo Pasha Pagan has done it, they found that whenever you have a varicose bleed and you give an IV beta blocker, and if the HVPG comes down to below 10, that means the risk of rebleeding is very, very high. So in the Barcelona group, they did the study and said, if your HVPG is still higher after an IV beta blocker, more than 12, then you need to expect or predict a rebleeding and probably be for a rescue therapy like TIPS. This is what have shown, that's a sub-analysis, what was shown in the study which Hemomal has seen. I think beta blockers and EVL could be offered as a combined treatment, because beta blockers do prevent portal hypertension, and it has been shown that the progression of cirrhosis is equal to HVPG. Band ligation initially in an underpowered trials showed a better mortality, but as we progressed and in high power trials both had equal mortality. And of course, beta blockers, when they used in decompensation, the problems of progressing to AKI, SBP was much higher in this particular group. These are my comments for this particular debate. Dr. Wadhwa, you want to sum up?
Yes, I think we have, we can safely say that in a subgroup of patient, which is a high risk varices, which we define it as, prior to decompensation, probably beta blockers will help in prevention of decompression, and endoscopy will reduce the risk of bleeding. So a combination of initial obliteration of varices followed by beta blockers could be an optimal choice of therapy. In a small varices with high risk signs, beta blockers remain the drug of choice. And in those decompensated patients with small varices also probably should undergo only beta blocker therapy. I can only feel that Dr. Sethubabu's comment on adding statins, statins probably will be useful in the pre-primary prophylaxis where the fibrosis is minimal, so that a reversal of fibrosis can be achieved. And statins may not have much benefit when you have already decompensated and you are in an advanced stage of cirrhosis of liver. So I don't think combination of these drugs in the later stage of cirrhosis of liver is going to make any difference in the outcomes.
Agreed.
Thank you very much, Dr. Wadhwa and Dr. LVK, and to Hema as well as to Dr. Chalapathy for this wonderful session. We now move on to the last session. We request Dr. Palanisamy and Dr. T.S. Chandrasekhar to take over, please. Dr. Nageshwari is joining us.
Good evening to everybody. My co-chair, Dr. Chandrasekhar, will be joining online. Dr. Nageshwari needs no introduction for all of us. However, I would like to mention a few words which some of you may not be aware. Dr. Nageshwari is alumni of Chennai. He did his MD from Madras Medical College, and also his son-in-law of Chennai. His wife is from Chennai. And Dr. Nageshwari, as you all know, is a great endoscopist and academician. He has received numerous awards and the honors. I just want to mention one or two. And he is the first Indian to receive Crystal Award from the ISG, and also received the recipient of a Padma Bhushan Award from the President of India. Over to Dr. Nageshwari.
Thank you, Palani. Thank you very much for the kind introduction, and I'm honored but I'm speaking at the Indian Society of Gastroenterology Tamil Nadu chapter because I think, as you said, there's a soft corner for me for Tamil Nadu. Mainly, of course, it's an association for long. In fact, I will share my slides. In fact, when I was in MMC doing my general medicine, I think Palani was actually doing his DM, if I remember right. He was assistant professor doing his DM, I think. And Dr. Jayanti was in CMC Vellore at that time. And Ubal Das asked me to talk, and then he titled this as Goat from High Tech. I'm not sure what it meant, because goat, usually nowadays you have a goat symbol coming up in the emojis in the cell phones and all that. Then I Googled and I was very happy when it said greatest of all time, but then I realized it also means generally, obviously, and tedious, which probably applies to this talk because it's the last talk, everything is delayed. We probably have, people are waiting for the dinner. So what I'll try and do is try and be as brief as possible. So like Palani mentioned, I was in Madras Medical College, did my MD at 80, between 79 to 82, at which time gastroenterology is very primitive. My own interest was in hepatitis B because that was, at that time, Bloomberg was in Chennai, actually, in Taramani Institute. He had come to visit there, and it was very exciting to know that. And in fact, my first publication, major publication, was in Lancet in 1984, when we looked at vaccine protection against neonatal hepatitis B carrier state. And I was very interested and almost went to Professor Sheila Sherlock to continue my pursuit in hepatology, and then got deviated into endoscopy and came out of this, and probably are not intellectually suitable for hepatology and more mechanical. Endoscopy suited me. So anyway, at that point of time, I still remember, and those of you in Chennai would still remember Professor Madan Gopalan, and he was really truly inspiring figure who inspired many of us into the field of gastroenterology. He would be very clinical, very methodical. I think he was one of those no-nonsense persons who would talk very up to the point. So he was a big influence, and gastroenterology itself was extremely primitive. The scopes were very thick. I remember, I think Dr. Raghuram was doing all the scopes at that time in MMC, and we used to get a little peek into the scopes at that point of time. But over a period of time, of course, things have changed dramatically. When I first told people that I was taking gastroenterology, and I'm sure some of the seniors here, like Setu Babu is also here, would have actually, when we were telling people that you're taking gastroenterology and not cardiology or neurology, people would tell us, how come, what is gastroenterology? The specialty, gastroenterology was totally unrecognized. There were few giants in that field at that time, including Dr. Madan Gopal and Dr. Habibullah was in Hyderabad. And of course, we had Dr. Tandon and Dr. Mehta and so on. But overall, and of course, Mathan. And overall, the gastroenterology as a specialty was not recognized at all. But see the difference that has occurred over the last 40 years. I think there's a dramatic change in gastroenterology. It's now become the first specialty that people want to take. And of course, it's becoming increasingly important, mainly because of better understanding of the pathophysiology of various diseases, a huge impact that molecular biology had on gastroenterology, and of course, the extraordinary improvements that have occurred in endoscopy technology. All these have made gastroenterology a very exciting field now. So when, again, Ubbal asked me to talk about what is going to happen on the next 10 years, I was happy it's only 10 years, because many times you are just asked about future, next 20 years, and you know that you're not going to see that. At least next 10 years, hopefully many of us here will live to that time to see what's going to happen. I took out my crystal ball to see what's going to happen in the field of gastroenterology, and let me show you some of the things that I thought of. Again, it's a very, very broad field, so I'll try and cover a few areas. And let me start with hepatology. And as I said, that was my initial interest. Hepatology is a science which changed dramatically. And you can see this. This is, again, data from our hepatology clinic here in AIG. You can see that there is a dramatic drop in hepatitis B and C. Of course, patients are getting better care. Most of them are treated in primary centers. Marked increase in alcohol and NASH-related disease. And this NASH is the focus that's going to come, because I think we have this adipose wave that's coming in, NAFLD parallels rise of type 2 diabetes mellitus. And I think the most important key to future gastroenterology and what's going to happen over the next 10 years is the riddle of solving progression from NAFLD to NASH. I think, of course, this will involve large-scale public awareness programs. But what what I'm seeing now is that there's a definite shift towards people. In fact, a few years back, when people used to come to us with grade 1 fatty liver ultrasound reports, we used to sort of joke and say maybe the ultrasonologist is giving many of these reports, but looks like it's changing now. And increasingly, a concept of metabolic disease where you find NAFLD, diabetes, obesity all coming together into a fraction is occurring. So I think one of the most important things that has occurred in this is, of course, we have been knowing that lean NASH has been reported from India for very long. So why should lean NASH occurs? And of course, now we know that there's a strong genetic association. And in our unit now, a patient coming in with NAFLD would always do this genomic analysis to see the potential progression of these diseases. There's regional differences in different parts of the world, but I think in general, especially in lean NASH, these genetic differences make a difference. So in future, maybe 10 years back, when you're going to see a patient with NASH, our main intention would be, or a patient with NAFLD, our main intention would be to see that the progress into NASH doesn't occur. And maybe we'll have a lot of additional armamentarium with us, like, for example, nutrigenetics and all, which would be available to treat these patients. Regenerative medicine also is becoming very important in hepatology. And of course, this is an area which is very exciting because we now have the potential both to take hematopoietic stem cells, the CD34 cells, and mesenchymal stromal cells, to use them in patient liver. And of course, our stem cell lab at AAG has been quite active for some time with these types of technology. We are now been able to isolate CD34 cells very easily in our lab. And of course, this is a paper that Mithun and his group published, where they injected these isolated cells into patients with decompensated liver disease and have been following them now for 4 or 5 years, showing very clearly when you actually infuse this CD34 cells, you can actually produce a compensation. That is, these patients, ascites goes off, the liver function tests improve, the renal functions, and acts as a bridge to transplant. Can this become a permanent solution in future? Maybe 10 years, 2032, we are going to see patients coming in with cirrhosis. Instead of suggesting a direct transplant to these patients, we would suggest probably that these patients should actually undergo stem cell transfusion. And especially if you combine CD34 with mesenchymal stromal cells, which are predominantly anti-inflammatory cells, we have had very encouraging results. So I think future therapies in this direction would be towards regenerative medicine and stem cell therapy rather than gross transplants that we are seeing now. And of course, extending this further, we are using this in our inflammatory bowel disease. Again, I think 10 years from now, in many patients with IBD, we would be replacing this type of stromal stem cell therapy rather than using biologics that we're doing now, not only because of the cost factor involved, because of the efficacy. This is a very promising area, and I see that IBD is going to progress more towards this area. One of the most exciting areas in gastroenterology is the human microbiome, and this is an NIH project which is over the last 10 years has sort of mapped out all the cells that we have. We now know that only 10% of cells in human beings are actually human cells. 90% are actually bacterial cells and bacterial genomics that actually control most of what is happening in our body. Fecal microbiome transplantation, FMTs become standard of therapy in Clostridium difficile, is becoming very active with IBDs, IBS, obesity, liver disease, and so on. But this is something, again, in future, I think over the next 10 years or after 10 years, many diseases, not only gastrointestinal, but also non-gastrointestinal, are going to be treated with FMT. For example, this is a study that we published some time back where we show the differences in IBS patients. But in IBD, there seems to be a huge explosion in this area because of several studies that have been published recently. We know that the gut microbiota is actually controlled by diet, and there seems to be an increasing tendency for us to manipulate this diet in these patients. And there's some very exciting studies come. In fact, this is a study where we actually doing with the Israeli group, where we're doing a microbiome-based dietary modification, looking at producing bacteria with short-chain fatty acids so that they can modulate what is happening in terms of IBD. And you can see that these patients are given the so-called Mediterranean diet. In fact, we are training our cooks in the hospital to do this so-called Mediterranean diet, And then when you see that these Mediterranean diets are given to a group of IBD volunteers who can take this diet, and we find that there's a dramatic decrease in their disease. And hopefully 10 years from now, in addition to all our medicines and all, we're going to cut down on many of these toxic medicines that we give to these patients and treat them with modulation of our microbiome with diet. So this is, I think, going to be more and more important. But very exciting areas are occurring also in gut-related microbiome. I think this is an example of a paper published in Nature a few years back, where obese mice, the stool of the obese mice was fed to a germ-free mice, which when they took this stool sample, it became obese. Whereas if you take a lean mice and feed the stool sample, these germ-free mice were lean, indicating that there was a strong control on various bodies' metabolic systems with this microbiome. And I think this is something that as gastroenterologists, we have tremendous advantage of other specialties, because many diseases in the next 10 years are going to be related to microbiome therapies, even right from depression to dementias to other cardiac problems and so on are going. So I think we have this advantage because we have the ability as gastroenterologists to deliver this microbiome into various parts of the gut because of the endoscopes that we have. I think also microbiome changes are going to play a very important role in metabolic diseases. And this is a study, again, which came from our unit from Roop Jyoti and his group, who showed that in patients with chronic pancreatitis, with and without diabetes, there's a remarkable difference in the type of microbiome. You can see these controls without diabetes, chronic pancreatitis without diabetes, and chronic pancreatitis with diabetes. There's a definite difference. And the belief is that if you actually feed patients with chronic pancreatitis with diabetes a certain group of microbiome, you can actually reverse that diabetes in these patients. And these are some very exciting studies that Roop is starting to publish, both in type 1 and type 2 diabetes. There's a definite correlation with certain type of microbiome. And also there's evidence from the literature that the progression of the pancreatic cancer, for example, is influenced by the microbiome that is there. And these are, again, a paper in Cell, which was published 2 years back, which showed very clearly that there are certain types of microbiomes which are very positively impacting on the prognosis of patients with pancreatic cancer. I think, again, very, very exciting information that's coming. Last year, Emmanuel Carpenter and Jennifer Diodena received the Nobel Prize for a technique that they developed called CRISPR-Cas9 technique. This was a technique which was used to edit DNA, and I think this was a very exciting technique which was taken from Nature, which they could implement it, where they used this guide RNA and a cutting protein, identify the fault in the target DNA, cut this target DNA and repair it. So this CRISPR-Cas9 technology is now becoming, I think, a very important tool. There are many problems with this in terms of ethics involved, because we know, of course, that a Chinese doctor did this in an embryonic stage and then produced babies which are resistant to HIV. There's a lot of hue and cry with that, and a lot of moral questions that were asked. So this is progressing slowly, but I think it's got a huge potential because this is not a difficult technology. In fact, in our basic science department, we have this DNA cutting machine, which is very small, it's very easy to use. And of course, we are using it in patients with hepatocellular carcinoma, culturing these cells and trying to see whether we can incorporate different types of genomic immunogenic modalities in this to see how they'll respond. But generally, I think this again will be the future, where many gastrointestinal diseases, for example, if you have a patient with hereditary pancreatitis, in the embryonic stage itself, you can actually do a CRISPR-Cas9 technique and remove the abnormal gene sequence that is there. I think this is something that we'll have to look for. And this, after, in fact, 10 years, I think is a very long time. I would see that next 5 years, in many of the diseases, these types of technology are going to come in. And in gastroenterology, certainly, all monogenic type of dysfunctions that are there can be very easily replaced with this gene manipulation technique. And again, you can see the example that we recently, there's a huge news about pig heart transplant that occurred in Maryland, US. This was possible because of CRISPR-Cas technology. They could modify the genes on the heart to make a porcine heart into a pig humanized heart. So same thing will happen with livers, I think very, very easy. And that again is the work that's going on now, right now, where they're able to humanize pigs' livers, produce antigens on these surfaces, HLA antigenicity, which makes it much more friendly to human immune system. So probably in 10 years time, we'll see large pig farms with humanized pigs, with humanized livers, which can be transplanted, so that it becomes very easy. And again, this is not a distant future. This is already occurring. There is now a company in US, in Virginia, which is able to produce a humanized liver now from a pig. So I think we'll see the transplants coming in. The other area, which again, next 10 years, we're definitely going to see, is going to be in precision medicine. The so-called personalized medicine is what everybody talks about, but it's coming in very, very rapidly. In fact, this is something that I wanted to actually show you. This is, if you actually see, this is a confidential report. So I'm not supposed to show this to you, but anyway, I'm doing it. Because what happened is, our pharmacogenomics guys told me that nowadays, we don't prescribe drugs. So if a patient comes with heartburn, or patient comes with, say, dural ulcer, you just don't give PPI 40 milligrams once a day and say, okay, come back after 2 weeks. Because the pathways of each drug is different in individuals. So you have to individualize drug therapies. The FDA has now given permission for 340 drugs to be optimized during these pathways. And in our hospital now, we actually started doing for 6 drugs. So if a patient comes with GERD and you want to give a PPI, so writing 40 milligrams of esomeprazole, jacking it up to twice a day or thrice a day or whatever it is, we now look at the genomic pathway of how it goes in this patient and then prescribe. This is an example, my own example. When I looked at, when they looked at my genomic pathway of how esomeprazole and all were going, you can see I was a poor responder, which means these drugs were getting metabolized very rapidly. And if I had to take esomeprazole, if I had a GERD, if I had to take esomeprazole, I'll have to take that double dose from beginning itself. Whereas somebody else who had a very good response would have to take half the dose. So I think this sort of personalized medicine is just coming in. And my belief is that within the next 10 years, at least for 200 to 300 drugs, we are going to start using this so that patient quickly gets a pharmacogenomic profile of the drug is going to take. And again, we are using this very commonly in the field of clopidogrel versus PPIs. When you use them, we're now getting a pharmacogenomic study done before these are prescribed, whether they can be co-prescribed, whether they have to be separated in the prescription and so on. So this is another very important area, I think, that is coming in. Artificial intelligence is another commonly talked about, and something which hasn't still come in very, actually in general gastroenterology, but a little more into endoscopy, where we now talk about machine learning, deep learning, and so on. I think some of us have to get used to these terminologies. There's a huge application of artificial intelligence in general, but I think it's going to be a combination of artificial intelligence, digital medicine, and genomics, which are the next 10 years. I know of many startups in Hyderabad now, which are working in this area, whereas digital medicine with artificial intelligence and genomics combined together. For example, if you prescribe a certain drug to the patient, he then goes and wants to know how to take it, when to take it, what period of day is best for him. All those things can be answered using this type of combination. And coming to my own area of interest, which is in endoscopy, I think this is where major changes are going to occur in next 10 years, because this is the technology dependent area. And whenever technology dependence is there, if technology is progressing very rapidly, it's going to change. I've just actually come back from a symposium in Japan on single-use endoscopes. And now the view is that in the next 10 years, most of our endoscopies are going to be by single-use endoscopes, sterile endoscopes, because of the concern of infections, and this COVID pandemic has pushed us towards that. People may say, what about the cost? You won't believe it now, but there are companies which can produce a single-use endoscope for $50, which is about 3,500 rupees. They're able to come out with single-use, and cost will come much lower. It's like using single-use accessories. And the quality of these scopes are fairly good. You can see, so this is the endoscope, which is now available for $300, and this is a single-use colonoscope. A little different it looks when you operate it, but when you actually go inside the colon, you can see the pictures. Absolute great quality of pictures that you have. So these are going to come in future, and they're going to replace the regular endoscopes. Already we have started using, in fact, in our center, we have started using the single-use duodenoscope. Cost is a factor now, but it's going to come down. In fact, we have had opportunity to demonstrate this in several endoscopy workshops now. You can see the quality of the scope is as good as standard scope. So as I foresee it in future, the next 10 years, a lot of areas, emergency medicine, ERCP area, in a lot of these areas, we're going to use single-use endoscopes because you can see the quality is great, infection chances are very low, and the costs come down. Many patients would prefer this, and you can see the major advantage of this is not only can you do proper therapeutics, but after the procedure is over, instead of storing the endoscope, you can see like what we're doing here, just put it off into a waste paper basket and it's gone. So will this become a reality in 10 years? Definitely. In many areas, for example, in emergencies, in ICUs and all, we can already see it. But in 10 years' time, the cost of the scope, the quality of the scopes are going to become so much better that I have a strong feeling that single-use endoscopes may become something that we're going to commonly use. And similarly, robotic endoscopy, the surgeons have been using it for very long. We, of course, did the first human flexible endoscopy, robotic endoscopy, and many companies are developing this. Again, next 10 years, these are going to come. Optical biopsies, again, we are using, and these are going to become much more common, like, for example, OCT and NBI and all are being used. And I think more important is a combination of artificial intelligence with optical biopsies, where I think CAD-E and CAD-DX are something that we're talking about commonly, where we can actually detect a polyp and also characterize the polyp. I think some of you attended a workshop 2 years back. This is already reality. We're now starting to do this endobrain very commonly. This is Professor Kuro from Japan demonstrating on endobrain that you can, using this AI, you can make an endoplastic lesion. You can say whether it's the chance of it being malignant or not, very high chances. And similarly, molecular bioendoscopy in 10 years definitely is going to be a reality with us. We're getting many devices. Again, for example, in patients with GERD, this was a study that we published in Gut recently, where we showed using this GERD-X in patients who have to take long-term PPIs or don't want to take this kind of effective method. So these, I think, are going to become common in clinical practice in 10 years' time. And of course, we know about single-use cholangioscope, already used very commonly, so that we are starting to do fluoroless ERCPs now, and very difficult lesions which are indeterminate here. The answer can be got by doing a cholangioscopy in terms of either it's a lymphoma here or tuberculosis here. These are getting more and more sophisticated. In the next 10 years, we're going to get cholangioscope with a spintrotome attached with guide wire, everything. So you have a single device which can be used as a spintrotome, stone extraction device, cholangioscope all together. So we don't have to change our instruments. I think these are going to be common use as we're seeing it now. Of course, we have moved away from plastic stents now to metal stents in all patients. In fact, already we can see these plastic stents are becoming into a graveyard of endoscopy accessories. Metal stents are taking over, a new dawn is coming, and the variety of metal stents for different indications. So my take is that after 10 years, we no longer will have these plastic stents. Everything will be replaced by self-expanding metal stents because of the ease of use, for the capability to be removed and so on. And coming to an area where, again, it is developing very rapidly, endoscopic ultrasound. What is going to happen in 10 years' time? I think a variety of new indications are coming in. PTBD is being rapidly replaced by endoscopic ultrasound biliary drainage, and there's a lot of evidence to suggest that this is the right way to go. We are not going to do PTBDs 10 years from now. It's going to be endoscopic ultrasound guided biliary drainage. In fact, endoscopic ultrasound may even replace ERCP as a primary modality of drainage, biliary drainage, as we have evidence for that coming in now. We are going to use this more also for a patients, for example, gallstone disease in whom surgery is not possible. We can do an endoscopic ultrasound guided removal of the stones, and again, data on this is there. But the most important future indication for US is going to be in patients with gastric aortic obstruction. We are going to stop doing GJs now. Believe me, in 10 years, we won't be doing surgical GJs. All of this will be replaced by endoscopic guided gastrojejunostomy, which is already becoming a reality now. And in 10 years, it will be a definite reality. I think surgeons will lose the skill of GJs because endoscopic guided gastrojejunostomies are going to be the reality. And this is a technique that, again, I don't want to go into details, but can be very easily shown. We had a lot of discussions on varices, banding, and so on. I think the future treating difficult gastric varices is going to be not by glue injection, but a combination of glue coil under endoscopic ultrasound guidance, which is going to give us much better results. We are going to go US guided tips, vascular stents, aneurysm. All of these are being done already, but I think these are going to be refined better, and we're going to get scopes in about not in 10 years, in 5 years. I see a situation where we have a scope like this, which can do a combined endoscopic ultrasound and ERCP guided procedures. We are entering into other areas which has been traditionally surgical areas. For example, bariatric surgery, laparoscopic bariatric surgery is being rapidly replaced now with the endoscopic sleeve gastroplasty. I think comparative results are now available from big centers, and even in our center, we have shown that endoscopic sleeve gastroplasty is as good as laparoscopic sleeve gastrectomy. This is an area which is going to become very common. And similarly, I think this is something which has come in Europe, but going to come in our country also. In 10 years' time, many patients with type 2 diabetics are going to be treated with the duodenal mucosal resurfacing procedure, where the duodenal mucosa and the second, third, and fourth part of the duodenum are going to be replaced after a thermal injury with normal mucosa, and diabetes can be treated. Not only diabetes, but all metabolic parameters can be NAFLD and NASH. Of course, insulin sensitization occurs. So many of the metabolic parameters, including lipid profiles, can be changed by doing this. And here, I think the gastroenterologists are going to play a major role. Gastroenterologists are going to transit in the next 10 years from being plain clinical gastroenterologists to metabolic specialists. I think we have to start in our gastroenterology departments, metabolic departments also, because we are going to be the prime movers or treaters for metabolic diseases in future. Next 10 years, metabolic diseases are going to be a very important component of a gastroenterology profile. Believe me, that's going to occur because they're getting new methods. Of course, third space endoscopy, all the advantages that have occurred in this already taking over, they're going more and more, so that many traditional surgical procedures are replacing by third space endoscopy, and especially draw attention to gastric poem, which has been a neglected area. And we now have evidence that if these patients are properly evaluated with the manometry, endoflip, and so on, there's a large number of patients with recurrent vomiting, diabetic vomiting, or postoperative vomiting will greatly benefit from these procedures. We are also becoming very good at closing perforations, iatrogenic perforations initially, but all sorts of perforations. So endoscopy, I think, is going to take over surgery, and these barriers are going to be broken. In 10 years' time, it's very difficult to distinguish a surgeon and an aggressive endoscopist. Probably surgeons will also start doing endoscopy, and endoscopy will become surgeons. So this change in behavior is going to occur very rapidly, and I can see that already partly occurring, but it's going to become much more rapid. But before I end, although all these advances have occurred, I would still think that clinical medicine is extremely important. And this is in memory of what Dr. Madan Gopalan used to say, that I think medicine is still a combination of art, science, and empathy, and we should forget this. Whatever happens 10 years from now, 20 years from now, the human touch is still going to be very important in medicine. All advances are going to occur, but this will remain still a part of medical practice. Thank you once again for giving me this opportunity.
Thank you, Dr. Nagi, for that excellent lecture. I wish you continue to stay in Chennai as a son-in-law and created an AIG here. Over to Dr. Chandrasekhar, my co-chairperson.
Nagi, I was about to ask you what is the fate of clinical medicine in 2032. But the last slide really made it great that clinical medicine is the real foundation on which only we can thrive. Number one, being a hardcore endoscopist, and you started with the hepatology, with NASH and lead NASH, and fantastic and hepatocellular carcinoma, how you can modify the stem cells. And what I like the most is how can you personalize, like you have a personalized service for every field. How can you give a personalized medicine? And you shown your own data that you need to take twice the dose of esomeprazole. That's a great, Nagi. And usually give a very good talk. Fantastic, but this today was excellent. And you covered luminal gastroenterology, hepatology, and the endoscopy. Of course, you said everything and possible, and you are very balanced that US may replace even ERCP, even though our hardcore area is ERCP, but you did not mince word to tell that US might replace PPDD, US might replace ERCP, and everything is covered. In 20-30 minutes, you have covered the entire spectrum of I don't think you just looked at the horoscope or the crystal ball. This is the authenticated information. You got it. What is needed now, that will be answered within 10 years. I think the need of the hour, that's what you did. Fantastic, Nagi. Thank you.
Thank you.
And one question from Dr. Taimanavan, how will you degrade environmental degradation of the single usage scope?
Yeah. So that's a big question. In fact, we just had a symposium in Japan on this, and one of the major questions that was raised was how we are going to deal with the environmental contamination with all these so many scopes. They're in fact devising new types of incinerators for this. What you do is you do your scopy and not throw into the waste paper basket, but each hospital will have a special incinerator which will convert these disposable scopes into material which are going to be useful in terms, for example, you can use it for your gardening and so on. So that type of technology is coming in so that we don't load the environment with all types of things. So this is the simpler part of things. The more important part is trying to cut down the costs, and we have to be very careful about that.
Nag, in the lighter sense, you had the youngest audience today. My 2-year-old grandson was listening to your talk. I'm seeing after 2 years after he was born.
Yeah.
So he was so excited to see you.
So I think his junior TSC potential future.
Any question from the audience? Such a lovely talk Nagi gave. And 2032 is not. And other statement he said, I'm very cautious because 2032, hardly 10 years, we are all going to see the changes. If it has been 20, 30 years, we can tell anything. Because
Nagi,
so that's why I think every single thing, Balaji, what I meant is every single thing I told you what's going to happen in 2032 is happening now. It's the beginning stage of what we're seeing. And these are going to mature. And by 2032, all these things that we're seeing right now are going to become more mature so that they become routine use. Bala, go ahead, please.
Yeah.
Bala?
Even after 10 years, are we not going to have any facility to remove the asymptomatic gallstones? No mention made about that.
No, but I don't think we have to remove asymptomatic gallstones. Is there a need at all? I think asymptomatic gallstones are like moles we carry. We just carry them throughout our life. They're not causing any problem. There's no indication at all in tackling them. They're part of our natural ecology.
Nagi, is it possible to endoscopic cholecystectomy?
Endoscopy
surgical colleagues may not like this question.
No, this has already been done. In fact, we in the notes when it came in early, in fact, just about a month back, we had this live workshop transmission from Shanghai, where I think they clearly showed the transgastric, because now transgastric approach to peritoneum also has matured. When we started this 10 years back, we were not very sure. We used to make an opening closure difficult. Now using this flap technique, we can go in very easily into the peritoneal cavity and do a cholecystectomy-like procedure. It is, we can see it in many live workshops, but the problem is, what's the purpose? If lap is easier, why not do lap rather than do these types of procedures? So technically possible. I think we've come to a level where it becomes not very difficult to do it. But if you compare head-on, for example, if we look at bariatric endoscopy now, definitely endoscopic sleeve gastroplasty is going to be superior to lap sleeve gastrectomy for several reasons, cosmetic, anesthetic, and so on. And if you show it's equal, then it's better to do an endoscopy rather than laparoscopy. Whereas for laparoscopic gallstone disease, it's much easier laparoscopically rather than endoscopy.
Thank you, Nagi.
Any question, Bala? Professor KRP, now everyone is asking when is the dinner?
Yeah, I think people are waiting for dinner. Probably you can wind up.
2032.
Yeah. Is there any way to postpone the dinner with your talk?
Chandrasekhar, you let others also talk. This is Krishnan here, Nagi.
Hi,
and,
sir.
You raised the scale so high that I don't think you got to put over in future. It's a wonderful kaleidoscopic view of what's happening and what's going to happen later. And there can be controversies and a lot of discussions on what you're saying, but I'm glad I came. I say only one of the attractions that made me come here today was you, and I'm glad I came. It's wonderful, wonderful. Keep it up.
Thank you, sir.
And about this 10 years, I must tell you, you said 10 years, no?
Yes,
That
yes.
gives me an incentive to definitely live for 10 years more.
Well, you'll do that definitely. I think some of us may not be there, but you'll be there.
I think nice comment. Any other questions from the audience and the faculty?
Can you see the audience?
Yeah, we can see actually.
Oh, good, good.
I'm
good.
surprised that we have a significant number. I think all of them have already had Omicron, so it's okay.
Dr. Jayanti then is to call it a day.
Dr. Ubal can take
Professor
over.
KRP, Bala.
I am happy to announce the result of today's case presentation. I would like to congratulate the winners. The first prize goes to Dr. Sagar from MS Ramaya from Bangalore. The second is Dr. Vijay from Trivandrum. Thank you.
And before you close, maybe one more comment I wanted to make about Tamil Nadu Gastroenterology Society. I think whatever happens, it's such an active society. In fact, I would consider it as the best state chapter of gastroenterology in our country. Whatever happens to any other society, next 10 years, I can still see in 2032 also, same types of meeting going on in Tamil Nadu Society. Yeah.
Thank you. Dr. Ubal, Dr. Prem.
Yes, ma'am.
Dr. Ubal would like to make some comments, and then Dr. Prem can propose his vote of thanks. Dr. Ubal.
Thank you, madam. I think this is a wonderful meeting, and it was suggested by Professor Jayanti. And we sincerely thank all the chairpersons, faculties, and friends who gathered here. Prem?
Yeah, I'm there, Ubal. Good evening, all. And on behalf of the ISG TNC chapter, I would like to sincerely thank all our guest speakers, Dr. Matthew Philip from Cochin, Dr. Naresh Wood from Bangalore, Dr. Nageswar Reddy from Hyderabad for the excellent talks, and Dr. Chalapati Rao and Dr. Hema from Vizag and Dr. Hemamala from Chennai for their active participation in the debate. Next, I'd like to thank all the chairpersons, the judges for the PG session, like Dr. G. N. Ramesh, Dr. Setu Babu, Dr. Jayanti, Dr. Ramakrishna, Dr. Ravi, Dr. Pramanayagam, Dr. Rajkumar, Dr. LBJ, Dr. Satyaprakash, Dr. Prakash Zacharias for their active interaction. I would like to thank our patrons for their help, and all the teachers, senior colleagues, junior colleagues, and PGs for making this Southern Odyssey a grand success. Thank you all once again for making this Southern Odyssey a grand one. Thank you all.
Thank you. Thank you and good night. Thank you.
I would like to thank Raja and team from Sun Zignas for their help in organizing this meeting. Thank you all.
Thank you, Nagi. Thank you, TSC. Thank you, Dr. Setu Babu. Thank you all.